на що дозволили ще раз виступити з цією доповіддю. Сьогодні трошки більший зал слухачів. Отже, не працює. Ретинопатія недоношених – важке вазопроліферативне захворювання, в основному глибоко недоношених дітей, що в термінальних стадіях призводить до слабкозорості і сліпоти. Я все ще вважаю, що лазерна коагуляція була і є золотим стандартом лікування, яка призводить, за різними даними літератури, від 92 до 98% випадків до стабілізації процесу. Анті-VEGF – коротка історична довідка. І ще в 56-му році Джордж Вайс написав, що неоваскуляризація сітківки тісно пов'язана із станом відносної аноксії. 70-ті роки Юда Фолькман припустив, що ріст та прогресія пухлин залежать від здатності пухлин стимулювати та підтримувати васкуляризацію. 89-й рік вперше виділено VEGF з пітуїтарних фолікулярних клітин. 94-х вперше опубліковано ключову роботу, що гіпоксична сітківка продукує VEGF. 97-й Genentech ініціювала дослідження про бівасізумаб і підтвердила його мінімальну токсичність. 2004-й FDA дозволила бівасізумаб, 2004-й дозволено пегаптаніб, 2006-й ранібізумаб, 2011-й афліберсепт, і все нові і нові препарати з'являються, і їх буде чимало, тому що це справжня чарівна паличка для нас. І де ж тут ретинопатія? 2008-2010 рік, на хвилиночку, зараз 2021. Бівасізумаб для ретинопатії недоношених. 15-17 рік дослідження Rainbow про ранібізумаб для лікування ретинопатії. І 2019 зараз продовжується дослідження Firefly Study на використання фліберсепту. Вже завершена перша фаза, діти набрані, вже всі ін'єкції виконані, результати доволі непогані. І де ж тут Україна? Покази до використання антивіджеф препаратів в офтальмології. Неваскулярне ВМД, ви всі дорослі спеціалісти, ви все це добре знаєте. Знову ж таки, ретинопатія недоношених, бітроп, 2008-2010 рік. Ще до сьогодні офтальмологи, дитячі офтальмологи України не мають легального права використовувати антивіджеф. Я, чесно, дуже засмучена з цього приводу. Щоб ми розуміли, як працює анті-VEGF, може у нас запуститься відео. Отже, суть в чому? Недоношена сітківка, сітківка у передчасно народженої дитини дозріває 16-го тижня. З диска зорового нерва починають рости судини і до 36-го тижня сягають назальної сітківки, до 40-го тижня сягають темпоральної. Ось ви бачите, частина васкуляризованої сітківки, широкі звиті судини, вже є мембрана, ввели препарат і блокували циркулюючі фактори, регрес, мембрана розсмокталася, судинки доросли до кінця очного дна. Я буду використовувати терміни, просто для тих, хто не займається, це нормально, що ви можете не знати класифікацію. Значить, ретинопатія має 5 стадій. Першу, другу ми моніторимо, тому що дитина може одужати безслідно, не маючи ніяких проблем. В третій стадії, коли починають рости мембрани, потрібно лікувати, щоб не допустити тракційного відшарування. Четверта, п'ята стадія, часткове відшарування чи повне відшарування із відповідними наслідками. І ось тут зони. Перша зона – це ділянка коло з радіусом подвійна відстань диск макула. Друга зона – радіус до назальної частини сітківки. І третя зона – це вже периферія, те, що залишилося верхній і нижній сегмент та темпорально. Переваги лазерної коагуляції. Зазвичай це однократне втручання. В моїй практиці 99+ % дітей оперуються однократно. Структурований обмежений термін спостереження. Часто вже у віці 3-3,5 місяців я можу сказати, ваша дитина одужала, і відпустити дитину на свободу, тому що ці огляди доволі стресові, травматичні для таких дітей. Так, інколи спостерігаємо від до 5 до 6 місяців, але в основному це 3-3,5 місяці. Віддалені результати. Ризик реактивації мінімальний, і ці діти підростають, і ви, напевно, будете їх бачити. Будемо сподіватися, що віддалені результати будуть такі хороші, як і до сьогодні, але ми розуміємо, що це спалена, скомпрометована сітківка з можливими, звичайно, наслідками. Переваги антивіджеф, легкість використання. Насправді, зробити лазер недоношеній дитині не так легко. Це кілограмова установка на голові хірурга. Протягом 1 години складно дістати всі зони довора серата. І добрий лазер зробити нелегко. А ін'єкція швидко, гарно, під білі рученьки, все добре. Швидка відповідь. Не мені вам розказувати, як діє антивіджеф, бо він у ваших руках значно частіше, ніж моїх, до прикладу, ніколи. Кращий результат в полях зору – це основний аргумент, чим аргументують прибічники антивіджеф, тому що лазером ми спалюємо васкулярну периферичну сітківку, але знову ж таки, якщо це є друга і третя зона, основному агресивніший процес у темпоральних сторонах. Ці поля зору і так обмежені у нас в перенісі. Гострота зору і міопія. Знову ж таки, дисконтабельно, якщо лазер зроблений вчасно і є захворювання, агресивні захворювання, дозволяє зробити його ніжно. Ці діти, можна, напевно, їх порівняти з загальною групою в плані розвитку міопії. Часто вони її не розвивають. Недоліки лазера, трудність виконання, навчання. Відділення інтенсивної терапії новонароджених часто може бути проти. На щастя, в Охмадиті ніколи ні. Жодну дитину нам не завернули, але неонатолог може бути дуже стурбований тяжким станом дитини і тим, що його ще треба в годинний наркоз вводити. Якщо це не в інтенсивній терапії, а на вихожуванні, потрібно організувати операційну. І результати та інші ризики – відповідно, недоліки антивіджеф, відтермінована пізня васкуляризація. Такі діти мають спостерігатися мінімум часто до 2-річного віку. Уявіть собі, що подивитися дитину у віці 2-3 місяців, крайню периферію, деколи із гачком, а що подивитися дитину в рік. Як це не дивно звучить, чим старша дитина, тим більше її шкода. Рецидиви. Рецидив після антивіджеф, вони вкрай рідко виникають, але агресивність процесу зазвичай більш агресивна, ніж момент ініціального втручання. Утруднене тривале спостереження, ми обсудили палиця у 2 кінцях. Антивіджеф виявляють до тижня часу сировиці крові у цих дітей. Це незрілі діти з незрілими нирками, серцем, легенями, головним мозком. І цей антивіджеф, циркулюючи сировиці, впливає також, може впливати і на ці судини. Віддалені результати невідомі. Це є оф-лейбл терапія у всьому світі. Не впевнені щодо вибору препарату та дози. Експерти в світі сперечаються. По сьогодні ті, хто роблять це багато, вже мають свій протокол, але спільної думки поки що консенсусу теж немає. І інші ризики. Ретинальні крововиливи, катаракта, внутрішньоочна гіпертензія, макулярна тракція, відшарування сітківки, ендофтальміт. Хірургу простіше зробити ін'єкцію. І мені дуже шкода, що для певних випадків в моїх руках немає цього інструменту. Але коли він з'явиться, дай Бог, в Україні і для недоношених дітей, мій біль в тому, щоб не було зловживань. Тому що цю патологію бачить тільки офтальмолог. Якщо є ретинальна камера, це захист і лікаря, і пацієнта. Але... І от, до вашої уваги, очне дно. Я думаю, що це виклик навіть якби у мене була можливість використати антивіджеф, тому що не виключений інфаркт цих ретинальних судин після ін'єкції, але складно мені сказати, так ця дитина бачить. Я не знаю, це поразка чи перемога. Мабуть, станом на сьогодні це перемога, але повернувшись, розуміючи інші можливості, мабуть, не зовсім. Знову ж таки, дитина приїхала пізно, вже почалось відшарування, є ексудація. Ми робимо лазер, звичайно, продовжується прогресування. Хто з вітріоретинальних хірургів піде в таке око без ін'єкцій? Звичайно, хотілося б загасити трошки ці судини. У всьому світі батьки просто підписують, це колега з Британії надіслав згоду, які підписують, і це захищає лікаря. В Україні Якщо, не дай Боже, з цією дитиною станеться, це хворі діти, вони не просто маленькі, вони з групи ризику. Якщо з ними станеться якась неприємність, враховуючи, що це оф-лейбл терапія, і навіть 99%, що це не результат ін'єкції, ризик того, що хірург постраждає, максимально висока. Це ви подумаєте над тим, що я сказала. Отже, анти-VEGF – це є системне лікування локальної проблеми. Лазер – це є локальне лікування локальної проблеми. Препарат, доза, покази. Все це залишається під питанням. Я вже не маю часу говорити. Я дуже вам дякую за увагу.
Катюша, об'являєте мене?
Шановний Андрій Миколайович, з доповіддю «Індивідуальний підхід до вибору препарату та режиму введення при анти-VEGF терапії».
Ця доповідь у мене практична, і у мене є аналогія з заправкою бензину. Коли ми будемо заправляти анти-VEGF препаратами око на протязі багатьох місяців, і від якості того, що ми заправляємо, буде залежати, скільки буде бігати наш мотор. Тут те ж саме, хто вибирає анти-VEGF препарат? Пацієнт чи лікар? Я вважаю, що нам треба дати інформацію для пацієнта про всі препарати, які існують, або про ті, якими ми користуємося, для того, щоб він зробив певний вибір з самого початку. Як це робиться на заправці? Яке запальне краще? То, хорошо, я буду користуватись цим кращим. Але для того, щоб зрозуміти, яке найкраще, нам треба розуміти, як діє, що за препарати є на ринку. І тут найкращого, універсального немає. Нам треба вибирати між ціною препарату, силою дії, довготривалістю і безпекою дії. По ціні препарату є off-label, дешеві препарати, є...
Medication is off-label. It is certified. These medications are more expensive. In Ukraine, the difference may be 2 to 3-fold. Abroad, the difference may be much higher. The strength of action. In this case, the new medication is the winner. I am unable to provide clear data for now, but this drug dries the retina better. I wouldn't like to go down to promoting any specific drugs, but the drug is way better than any analogous medication in terms of drying the retina. Duration of action. Currently, there is a fight. There are short-acting medications such as ranibizumab and bevacizumab, and there are Q8 to Q12 medications, aflibercept and brolucizumab. The duration of action and the regimen is for us to decide in terms of duration of action and in terms of efficiency of blocking VEGF. The theoretical winner is aflibercept. It blocks for longer. It works for 71 days as opposed to 51 days for brolucizumab. However, these calculations are purely theoretical. In practical terms, the medications are very similar in terms of duration of action, but we will see to what extent practical experience will match the theoretical calculations. In terms of anti-VEGF activity, aflibercept is way better than any other drug, but conditions in every trial are different, so it is hard to compare precisely these medications. It is still to see which drug will win, brolucizumab or aflibercept. Clinical practice will show us who the winner is. What about safety? Do you have any questions on? There are some questions in terms of regimens, and immunogenicity of aflibercept is lower than that of bevacizumab. Regimens of administration are somewhat new here. Previously, we sticked with the treat and extend technique. It was also common to stick to these tactics, but for now, we use the new tactics, that is treat and control. This allows us to step back. We begin with Q12, and if the patient is unable to tolerate the dose, we go down. This is very useful because multiple patients on anti-VEGF treatment are unable to tolerate even for 1 month, and we have to go down. This is the third strategy, treat and control. This strategy allows us to decrease the interval between the injections. I call these patients sprinters. Sprinters are patients who respond well to anti-VEGF, but the effect is very short. So more frequent injections are necessary. We have 3 patients of this type in our clinic, and they require injections once every 3 weeks. So when we once we have the new medication, we switch those patients to brolucizumab. This is a clinical case. A male patient, 79 years old, AMD, wet form, 22 injections of aflibercept have been performed, and there was no response to the last injection. I know about some reservations here, whether not to inject, but we perform 1 injection of brolucizumab, and after 28 days, the response is great. The patient is excited. There is no exudation, but the effect is not for long to stay. The edema appeared even earlier than 2 months after the injection. The patient, one dose in 2 months is not enough for this specific patient. We continue treatment, we inject brolucizumab. The effect is great, but what do we do next? Do we inject brolucizumab or do we go back to aflibercept? Why the question? Merlin's study was completed early. It was the trial focusing on severe patients which did not tolerate, which require frequent injections, and this trial recommends avoiding frequent dosages because of high incidence of adverse effects. So a case-by-case approach is necessary in these cases. And our next talk will be given online, Sofia Michalewska, with a very interesting talk on vitrectomy of ILM with subretinal BSS injections for diabetic macular edema on one eye versus intraocular injections of anti-VEGF on the second eye, on the other eye. Comparative study. Unfortunately, we have no connectivity. So once the speaker gets connected, then I asking the next speaker, experience of brolucizumab in neovascular AMD. Igor Novitsky, 7 minutes. Welcome.
Тоді вийшла Зося Навроцька, тому ми повертаємось до онлайн.
We're going back online because we have connection with Dr. Navrodzka. We ask Ukrainian speakers to wait for the online speaker to deliver the talk.
Тоді ми налагоджуємо зв'язок.
Now we'll be establishing the connection with the foreign speaker. In the meantime, he will be talking on the experience of Brolicism. The speaker is not present here. So our next speaker, my Australian experience of Brolicism and how it will help Ukraine. Olena, Dubai.
Добрий день, шановні колеги. Я хотіла б провести свою
Good afternoon, dear colleagues. I would like this to be a discussion rather than just a talk. My topic is the topic which impressed me the most when I returned to Ukraine after 20 years of ophthalmic surgery in Australia. The first thing I confronted in my practice was patients who are unable to tolerate the financial burden of costly anti-VEGF injections. As I see, it is illegal to use off-label anti-VEGF in Ukraine. This problem is universal for our country, so I would like to tell you how it works in other countries, including Australia. Could you please give me switch the first slide? This is not the first slide.
Вибачте, будь ласка, за технічні неполадки. Теж так гаряче, але не так вологість набагато нижче, тому це переноситься набагато легше, ніж на Україні. Так, я можу сама переключати, так? Далі слайди. Більш всього, я думаю, що це питання, воно лежить в площині політичній і...
This is rather a political and legal matter. What do ophthalmologists in other countries do in this respect? In the USA and in Canada, over 70% of retina specialists use Avastin off-label. In Japan, there are no restrictions in using these medications. Same applies to Switzerland. In Australia, every retinal specialist will be using Avastin, and it is the choice number one choice. How do we make this decision? In those countries, in the country where Medicare really works, the government must reimburse the cost. And when they calculated the cost of Lucentis versus Avastin, the conclusion was obvious. These are millions which we have to pay and nobody knows what for, but the efficacy is identical. So common sense dictated and financial matters dictated, as well as this was seen as an opportunity to help multiple patients, numerous patients. How does this happen? There are retinal clinics which may have up to 50 patients in 4 hours.
You said that you are not allergic. Він вже підготовлений для ретинального
This is a
спеціаліста.
patient who was prepared for the retinal specialist. The nurses have measured intraocular pressure, measured visual acuity, and decision was made to perform the injection. Now the patient goes to the next room where everything is done. These are syringes which have been available for quite a while. All of these syringes were ordered in a nearby pharmacy.
Now I'm going to put a little tiny speculum on your eye, and if you would like to open your eyes for me and just look down into your right,
То мені не
that's the
потрібно
way.
збирати
Thank you.
пацієнтів на один день для того, щоб ділити ту одну
Well done.
vial of
And from now on,
Avastin
I'll
на
ask you to
So the
say-
injection is made in the room as you can see it. There are multiple publications worldwide covering the economical effect of and the cost effectiveness of using off-label Avastin. These publications come from different countries, from the Netherlands. Yesterday, you heard the talk by my good friend, Professor Rosenfeld, who was first to discover the use of this drug and who has been lobbying this drug worldwide. He agreed to share his experience with Ukraine yesterday, and he agreed to support Ukraine in this matter. Please look, this comes from his yesterday's talk. How much the US were able to save by 2021 as opposed to using the labeled drugs. The drug is used for retinal degeneration, diabetic retinopathy, and as you can see, $100 million is the amount of annual savings for the state. In Ukraine, as you know, the situation is quite grave in this respect. However, there are ethical concerns, and many countries were able to fight pharmaceutical companies which opposed using the drug. This same thing happened in Australia. At some point, we were confronted by representatives of the industry, but the community of the vitreoretinal community was very strong, and we made unanimous decision that we do use this drug. So pharmaceutical companies no longer raised the question. This is how the paradox develops. Rich countries such as the USA, Canada, and Australia, the UK, and others have the opportunity to use the drug freely. But in Ukraine, it is illegal to do that for our patients. I, as well as my colleagues, believe that this would be a great thing to have Avastin for off-label use legally, so that the doctors were not afraid of being punished or sued for off-label use of Avastin. There are actually two practical matters to be resolved by our community in Ukraine. First, it's the political will. The law needs to be passed by our parliament, which would allow us to use the drug in off-label way. There is some experience in that respect in our parliament. In November last year, a law covering off-label use of drug to treat COVID was passed. There was they waived requirements for any clinical trials. It took just 24 hours to pass this bill. That was it. The professor who talked yesterday agreed to share his experience with Ukraine officially. And of course, support from Ukrainian vitreoretinal community will be needed. We need Ukrainian pharmacists will be able to and will be allowed to take the technology covered by the protocol, by the guidelines shared by the professor from the USA whom you heard yesterday. This is the person who was first to support Professor Rosenfeld and who said, yes, these off-label drugs are legal to use. The law of the US permits that. And I believe in Ukraine, all it takes is the political will and unity of the medical community. If this bill were to be passed by the Parliament of Ukraine, that would be just great. This is the law. Parliament endorsed Bill 3268 on amendments to certain legislative acts of Ukraine on the treatment of coronavirus disease. This bill allows using anti-COVID medications which have not been registered in Ukraine without any clinical trials. The drugs are just used in Ukraine. As you can see, this is not that difficult. The problem is not that big. This decision had to be made by the Ukrainian parliament. And now comes the second problem. It's the compounding pharmacies. Pharmacies which would be prepared to prepare the medications, the medication off-label Avastin for us. I believe all over Ukraine, we are losing patients who cannot afford the financial burden associated with using the labeled medications. Thus, using this medication, we could improve, we could help more and more patients save their vision. Thank you very much for your attention. Thank you. Our next speaker is Sofia Mikhailevska.
Hello, ladies and gentlemen. I'm happy to speak to you today. First of all, I would like to thank Professor Nowicki for inviting me to be here with you. I have no financial interest to disclose. We must be aware of the fact that the global incidence of diabetes is growing all around the world. And along with that, all ocular complications of diabetes will grow. We must be aware of the fact that about 40% of people with diabetes will develop diabetic macular edema at any point of their lifetime. What about treatment? Laser is nowadays a little bit passé. The golden standard is anti-VEGF, but as we heard in the last presentation, the financial burden is very important. In this presentation, I would like to answer the question, what about vitrectomy in diabetic macular edema? We know that even if results of clinical studies are excellent, and even if patients in clinical studies achieve very good visual acuities, it is not exactly true in the real world. In the real world, patients do not come to each visit, and because of that, their final visual acuity is slower than that presented in clinical trials. Several years ago, we published a study in that we stated that vitrectomy might be a method in the treatment of treatment-naive diabetic macular edema. We know it removes glycation products and VEGF. It improves the oxygenation of the retina Of course, it relieves traction. And moreover, it can provoke some repairing processes. What is exactly the role of subretinal injection? Because in this presentation, I will show you results of vitrectomy, not only with eye lamp peeling, but also with subretinal injection of base salt solution. We know that it decreases the osmotic pressure and viscosity of subretinal fluid, and in turn, it promotes water transport from the subretinal space to the choroid. We know that when retina touches the retinal pigment epithelium, it might absorb nutrients and oxygen. Another mechanism is washing out cytokines and migratory cells. In this study, I will share with you the results of 28 eyes of 14 patients. It is a retrospective study, and in all these patients, we qualified always the better eye for aflibercept therapy, and the worst eye was qualified to vitrectomy with eye lamp peeling and intravitreal base salt solution. It is very difficult to compare between studies, especially in diabetic patients, and because of that, I think this study is of high importance because we had the same patients with the same level of glycemia, and we treated them with different approaches for each eye. And now what about the surgical technique? I always perform core vitrectomy and remove the ILM earlier stained with membrane blue. I remove it as widely as possible in the fovea area, and afterwards I use a 41 gauge needle in order to inject subretinally base salt solution, and with this approach, I detach the fovea. Afterwards, the patients have a fluid air exchange and are advised for 1 hour prone positioning and then the head down positioning until the next day. What about results? As we observed, this is the better and the worst eye of those patients. The better eye you can see here in green, the worst eye in red. The better eye, as I told you before, was treated with aflibercept, and the worst eye with vitrectomy. We see that central retinal thickness decreases and is stably decreased in the long term. And the time in which it approaches to decrease is similar between vitrectomy and intravitreal aflibercept injection. This is an example of a 51-year-old man, and you can see that he had multiple anti-VEGF injection and his visual acuity improved. This is the worst eye of the same patient. He has additionally an epiretinal membrane removed during vitrectomy. You can see that 12 months after surgery, he is stable, requires no further injection, and his visual acuity is 0.5. What about visual acuity? This is a logMAR scale, so the visual acuities might seem a little bit inverted, but you can note, of course, the green line is lower because those patients always had the better eye qualified for aflibercept injections. Nevertheless, in both eyes, we observed a statistically significant improvement in visual acuity, and also the time in which the best visual acuities were achieved were similar in regard to statistical significance. What about central choroidal thickness? Well, we observed that in aflibercept-treated eyes, the choroidal thickness increased. There was no statistical significant change in the eyes in which vitrectomy was performed. This is another case. This is a 70-year-old man. And we note that his final superficial fovea avascular zone was lower in group 2, and it was similar in both groups. What about reappearance of macular edema? We see that it is possible after vitrectomy, especially in patients with worse diabetic control, that edema reappears after surgery. We noted it not that often, in the first months, but we observed our patients for 6 years after surgery, and those who were observed for 6 years had a mean of 1 to 6 injections afterwards. As a conclusion, I would like to say that patients with binocular diabetic macular edema, in which the better eye was always qualified for anti-VEGF injections and the worse eye was always qualified for surgery, they had visual acuity improvement in both eyes, and the rate of improvement did not significantly differ between them. The final superficial fovea vascular zone was smaller in the eye in which vitrectomy was performed than in eyes receiving anti-VEGF injections. That might suggest that vitrectomy has at least a similar long-term protective effect on the development of diabetic retinopathy as anti-VEGF injections do. Performing vitrectomy in the patient's worse eye might preserve vision and reduce the future number of intravitreal injections. Thank you for your attention.
So, Zosia, thank you very much. You have always very interesting results. See you in Lviv next time.
Thank you very much.
Thank you. Bye. Дорогі колеги, я ще раз запрошую групу.
Dear colleagues, I welcome the next group of speakers, Demchuk, Andreychuk, and Novitsky, first experience of brolucizumab in treatment of AMD. 5 minutes. In that case, we have some time for discussion. I would like to thank all the speakers, especially Olena Kubai, who shared her experience of brolucizumab in Ukraine. At the moment, this is number one, maybe number two question in our country and in our Ukrainian Vitreoretinal Society. We have prepared a letter to the ministry. This letter may break through the wall and we will be allowed to do what we need, but I haven't been using brolucizumab for 8 or 10 years. However, although I was the first in Ukraine to use it some time ago, why did I make this choice? There are drugs which work better, work longer, and if you use an off-label medication, it's better to use a different off-label drug, something better than Avastin. However, the American school sticks to Avastin. All the problems, I would like to talk to address the community now. All the problems with Avastin in Ukraine were not initiated by patients. All these problems were initiated by colleagues. We love and like each other to the extent that we actually fight each other. This is the problem of our communication. It is not the problem that our patients face and raise. So I'm really for looking for ways to use different medications. There are more drugs to use. They will have various benefits and advantages, and we need to use the whole spectrum of drugs. Out of 4, we can choose 3. Would anyone like to take part?
Так, я дякую. Я з приводу те, що
Yes, I'm grateful. I would like to focus on the off-label treatment. There is a question that I keep asking myself. Why do the poor countries like the USA and Australia and Japan and Germany and Switzerland use Avastin off-label, but the rich country like Ukraine cannot afford it? Probably, if I'm legally allowed to use off-label medications, it is unlikely to be Avastin. But during the recent round table, our progressive colleagues from Mexico, from the UK, from the USA, and Africa. Even Africa. Are we a third world country not to be able to use the drug? And indeed, it is not patients who cause problems. I have been approached by colleagues who say that we are not allowed to use this drug. My summary is it is the most important thing that no fraudulent activity is present. We always need to focus on the patient's best interest. We need to treat the patient and not just the eyes.
І я ще хотіла б зробити таке запрошення, особливо воно стосується
I would like to invite our young colleagues, young vitreoretinal surgeons who are not afraid of anything. If anyone is willing to take part in the initiative lobbying off-label Avastin in Ukraine, please feel free to approach me. Recently, we have established another institution, IQF Ukraine, and I'm the medical director of this institution. Our mission is to help Ukraine lobby our interests in ophthalmology. My talk will probably be available online, and in my talk you will see the website of our organization, so feel free to visit the website and feel free to join us. I would like to join some insider information. Roche, the manufacturer of Avastin, will be adding ophthalmological indications to the label. What about the talk? We have 10 more minutes. Okay, so we will wait. Colleagues, is there anyone willing to join the discussion?
Я розповім про застосування інгібіторів ангіогенезу при
I would like to discuss the use of angiogenesis inhibitors in retinopathy of preterm newborns. At the moment, we are conducting a clinical trial comparing aflibercept and laser treatment for retinopathy of the premature inborn.
був проведена лазерна коагуляція, трьом я виконував ін'єкцію афліберцепту.
So 3 patients received aflibercept injections. 1 patient was treated with laser coagulation. 120 centers were recruited worldwide.
Клінічного дослідження розуміли, що можуть бути центри,
From the very beginning of the clinical trial, it was clear that not every center will be able to recruit at least 1 patient. In Ukraine, 4 patients were recruited and enrolled in this trial.
він працює цей препарат.
The drug works
Перераховано на цього
if the dosage is recalculated per the patient's low body weight. The patients have been followed for 1 year now. In the first phase of this trial,
не фазову, перепрошую, а частину.
they are now moving to the second phase. Apologies to the second part of this study, where they will be followed for another 5 years.
То це питання впливу інгібіторів ангіогенезу дуже
So the matter of angiogenesis inhibitors is very problematic. We all know that even a low dose of bevacizumab intraocularly causes decrease of growth inhibitors systemically, which is really important in children. I have experience of using multiple drugs in clinical practice. Children do respond to angiogenesis inhibitors. They are really sensitive to this. So in the age of up to 5, up to 7 years, we stick to half dosages. So the issues in the matter of using angiogenesis inhibitors in pediatric ophthalmology really requires being careful and cautious.
Дякую дуже за вас. Будь ласка.
Якщо дозволите, ще додам.
If I may,
Ми теж були в цьому дослідженні, ми не взяли жодної дитини,
we have been we have
we
joined this trial. However, neonatologists haven't given a single patient to us, but we need to be careful. The Rainbow study indicates that efficacy of laser coagulation is 66%. I'm not sure about who did this laser. This is not possible. And of course, a young doctor who is just beginning his practice can see this 73% for the drug and 66% for the laser. And the conclusion seems obvious. However, we do need to be critical when analyzing the studies, but we do need access to these drugs.
Лазерному лікуванні
What are the advantages of laser treatment? One of these is
відомо, тому що дія гіпертонію може завершити.
it is important that angiogenesis inhibitors may cease their action. This will not happen after laser treatment if it was done properly.
Васкуляризації або сітківка вже реваскуляризована, то може лазер.
If that is done properly, the laser may indeed have some advantages. However, the study must last 5 to 6 years in order to have proper follow-up and long-term data. Vitreoretinal surgeons typically combine laser treatment with preparatory anti-VEGF medications.
Протокол був там
This is the protocol is very rigid. There were only 2 techniques to choose from: laser treatment or anti-VEGF injections.
Дякую. Де доповідачі?
Thank you.
Ну, давай.
Where are the speakers?
Немає? Добре. Тоді ми ще чекаємо.
Looks like we do not have the speakers. We have 5 to 7 minutes for the speakers to show up.
Може хтось ще щось хоче сказати, тому що активність зали.
Do we have anyone willing to take part in the discussion?
Про поєднання з приводу комбінації.
I would like to
Те, що васкулярна сітківка після ін'єкції може
talk about the combination. Vascular retina may persist for a long time, and monitoring of a child is a difficult task to accomplish. For that reason, in some centers, the approach is as follows. If there is no vascularization after 6 months, they shoot with the laser. If the ischemia, where ischemia persists,
Добре, тоді ми
the laser is used.
2 хвилини починається наступна. Дякую дуже, що залишились з нами.
Thank you very much for being with us, and in 2 minutes we'll proceed to the next session.
Так, ну, але давайте перевіримо, чи ви мене чуєте. In 11% of cases, you can track that, and the peculiarity that it's resistant to pharmacotherapy, and the human is not a natural carrier, so Toxocara is not replicating, but it migrates in vessels, gets into the organs, encapsulates, and causes the immune inflammation and allergic reactions. So toxocorosis has some difficulties with regards to diagnosis. So mostly we look at clinical signs. The initiation, the beginning is posterior uveitis, vitritis, or papillitis. In clear media, it's possible to see the foci under the retina. The age when it starts, usually 5 to 15 years of age, and girls are more affected than boys more frequently. Lab methods, it's ELISA to look at the antibodies to Toxocara, but the practice shows usually it's a negative result of the test rather than positive, because the eye toxocorosis would not cause a marked immune response. Differential diagnosis, it's retinoblastoma, one of the diagnoses, and with retinoblastomas, usually there is calcifications, and there are masses in vitreous, exudative RD, and no proliferation. Proliferation is never there. Treatment of toxocorosis is anti-helminths medications and corticosteroids as well, but they're not too effective. Usually, if it's an inflammatory reaction, it's better just to use corticosteroids without anti-helminth medications. There are 3 major forms: chronic endophthalmitis, meridian uveitis, and submacular granuloma with epiretinal proliferation. Another typical forms as papillitis or the optic disc inflammation. We did the study and we decided to look at the efficacy of surgery in toxocorosis of the eye in proliferative stage. We included 8 children, 6 girls, 2 boys. The age was from 4 to 16 years, and the visual acuity up to 5% with light perception problems. With regards to surgery of toxocorosis, of course, we shouldn't expect getting high functional outcomes back, because a granuloma is usually untermacular or paramacular, and the goal of the surgery is to get rid of the traction component. If possible, we have to get rid of all, to free the retina, all epiretinal membranes, and do the reposition with posterior tamponade, and we use the silicone oil for that. The problem of the proliferation in toxocorosis is the following: the granuloma is encapsulated, it's very densely attached to the membranes, and the surgeon is it's almost impossible to get rid of, to excise it. If it's a chronic endophthalmitis problem under the retina, we can see a subretinal proliferation layer, thin layer. And of course, there is little hope for functions getting back. So this is the most unfavorable form of the disease. Surgically, it's not a beneficial thing. In toxocorosis, proliferation is vitreoretinochoroidal, choroidal. So it goes, scars goes through all the layers, and membranes are thick, and the retina is elastic but thick. And after the membrane excision, it's possible to work with retina. And attachment of the retina was achieved in 6 out of 8. It was atrophic, and focal foci of deep and hyperpigmentation were seen, and we saw the atrophic changes of the macula. In one case, in paramacular granuloma, we were able to excise it, and the study showed, investigation showed that there are inflammatory cells and fibroblasts and RPE cells inside the granuloma, but no signs of parasites. In the majority of cases, we saw the visual acuity improvement, but only in 2 cases, VA was more than 0.2 increment. And this slide shows the dynamics of the VA before the operation and post-operatively. You can see in half of the group, there is insignificant improvement of the VA, and in another half, well, still we see a good improvement of visual acuity. You can see a child with 0.4 best corrected visual acuity over the granuloma. There is an atrophic foci of the macular retina that was formed there, developed there, but still we find an islet of paramacular live photoreceptors, and we were able to form the paracentral gaze fixation. So sometimes that means that sometimes improvement is where we don't expect it. Sometimes that happens. So the ocular toxicorosis should be included into the algorithms of differential diagnosis in leukocoria. Proliferative membranes from granuloma go through all the retinal layers, and surgical excision of epiretinal membranes leads to restoration of retina and improvement of visual function. Thank you for your attention.
Дякую за доповідь.
Thank you for your presentation. Can you tell us, please? The next presentation is from Professor Sergienko, but he is now busy presenting in a different hall. So Nicholas is not going to present. Agnieszka, are you ready? So how do we manage vitreoretinal patients on an outpatient basis?
This is maybe not very dramatic presentation, but I would like to share my thoughts about how to deal with VR patients in the outpatient clinic, because sometimes it's not the surgeon himself or herself to follow the patients. We all know that pars plana vitrectomy right now, it's not a last resort surgery, but it can save sight, but also the eye, especially in endophthalmitis or severe eyeball trauma, when timing is crucial. Delayed trauma, I just would like to highlight, has its consequences. If you manage it later, it means sight loss or eyeball loss, as we can here see. So we can do urgent vitrectomies in that dreadful positions highlighted here, or relatively urgent that we can have a little bit more time, like macular OFRD, intravitreal hemorrhages, complications of cataract surgery, or fresh submacular hemorrhage. But we can also talk about elective procedures in all those highlighted here. Timing in macular surgery, it's a question and is still discussions, because everything is clear and vision is deteriorated. There are metamorphosias, edema. Then we go for surgery. But what if the patient has a macula like this? This membrane is discovered accidentally and patient is completely unaware about the problem. Probably we should closely follow that patient and implement the surgery if the vision drops. The same for the macular holes. Small might be observed, but symptomatic have to be operated. Another problem which we all the time discuss are partially thickness holes, because such a macula might be in the OCT for months or even I risk the thesis that years. So for example, this one of my patients, the vision was for 2 years for 0.8, but when it drops to 0.4, I decided to go for surgery. About macular edema, I think there were previous lectures, but I just would like to highlight that if the initial visual acuity is better, post-operative result would be better. So if the patient has an edema like this, you still consider surgery, but you have to inform your patient that it's not gonna be a great result, and probably you have to inject not only before surgery, but also after. About vein occlusion, I talked yesterday, so I skip it. Patients with floaters. this is the pain of my head, because I always discuss with them pros and cons. If their vision is good, I try to delay it or reconsult. And if it's 0.7 or less, I may consider surgery, but if uveitis, I definitely consult it with a uveitis specialist because it may be causative treatment necessary. Natural lens, also the big challenge. If cataract is present, combined surgery, for me, it's a definite. The same for monocular patients, just to maybe to spare them an extra surgery. If patient is over 60, maybe you should consider combined surgery, but definitely measure your patient, especially if oil is planned, but be aware in RD patients, in huge macular edema patients, that maybe we should, if we have a problem with axial length difference, we should probably consider to implant the lens from the biometry in the other eye. Lately, I was operating the RD lady because of RD that was 6 diopter difference between the eyes. Traction and cataract. My choice is either do vitrectomy first and cataract if it develops, or combine surgery, because the traction like this may progress to the central or even normal detachment very soon after cataract surgery. And it was one of my mistakes, my overlooked. That was an 86-year-old lady with very very significant cataract. We just overlooked that traction, and this is post-cataractose image. The visual acuity before was 0.05, but when I did vitrectomy, because of that central detachment caused by exacerbated traction, the retina looked nice, but the vision never went bad. Gas or oil? I just would like to highlight that what is obvious for us, it's not obvious for our patients. We should aware the patient when we plan to put even air or gas or oil, that poor or even no visibility when the gas is present. Sometimes head position is needed, and restrictions for flights and high altitude. And I remember once Professor Luca told me the story in Bremen, that the patient was operated in Bremen and lived in northern Italy. So she had to cross the Brenner crossing. And on the Brenner crossing, she experienced glaucoma attack. So be aware about this. Gas cataract, it shouldn't be a problem. So if you see it, just don't bother, it goes away. But inform the patient that VR surgery is not a cataract surgery. So visual acuity will improve slowly, and metamorphosias will diminish slowly, sometimes months, and definitely if oil, vision will be blurry. I think that the greatest achievement on anti-VEGF is introduction in the VR surgery made our life easier, and just would like to highlight that ideally in the proliferative cases in diabetic patients, it has to be given ideally 2-3 days before, maximum 7 days pre-op. Although with macular edema patients, we can consider longer period. And even if it looks fibrotic, it may bleed like hell. 1 day post-op, if you are not a surgeon and a colleague asks you to see your patient, just don't panic if you see blood or fibrin. If its hyphema is more than half, like here, it needs to be clean. But if it's less or there is fibrin, just give it more steroids. If hypotony, we all definitely have to check the wounds. If higher IOP, give hypotensive drugs. But remember that among these drugs, I will rather avoid prostaglandins because they may give the inflammatory reaction. Second follow-up visit, removal of the oil has to be planned, and it has to be discussed with the patient accordingly. Third follow-up visit, I skip this, but if cataract is present, just refer for cataract surgery or do the cataract surgery. One of my greatest requests, if you see rubeosis, especially if the oil is present and there is still an ischemia, don't be afraid to inject to the AC or even to the oil Avastin, because even if the pressure is higher, I did it many times and it worked and the pressure goes down. AMD and vitrectomy, we definitely should consider it if it is a tractional element. And if there is a submacular fresh hemorrhage, we can use TPA. I think it works beautifully. And allergy for steroids, it's not common, but it happens. If there is a patient who is allergic to steroids, and we know it preoperatively, just avoid triamcinolone, use green ICG for detecting the vitreous, it also works. And postoperatively, non-steroidal anti-inflammatory. Rebleeding, if it's vitrectomized, I am waiting for 1 month. But if there is thick, central vision threatened, or if you rubeosis, I reoperate earlier. PVR, it's just a highlight because it's a major and separate lecture subject. We usually, if the macula is not involved, wait 3 months to complete the full membrane formation. If the macula is involved, we operate earlier. Of course, it's not easy surgery. So my take-home message is very briefly, I think that it's a safe and effective procedure, but carefully consider in a proper time. Prepare your patient always for longer rehabilitation. Vision is not gonna be 20/20 next day or even a week after, but success is connected with the general disease control, especially in diabetics. Patient does not understand that very often. In elective cases, most of the time we can see the earlier, the better, and time-sensitive procedure, especially in trauma and endophthalmitis. Thank you for your attention.
Дякую. Нікола, ви готові? Так?
you.
Окей. Наступна доповідь.
And the next presentation,
Ніколас Лабаурі.
Nicolas Labauri, endogenic fungal endophthalmitis surgical treatment.
I'm sorry, I have to connect my laptop. That's why I will be last in this session, if it's possible. Thank you so much for taking the moderation.
Тогда у нас буде заміна, і Андрій Миколаївич Сергієнко.
Then Andriy Sergienko. So we will talk about embolism of the central retinal vein. So retinal embolism is a challenge, and our conference is full of challenges that we are discussing with regards to diabetes. So one, to me, it's a challenge when we talk about the diseases and pathologies we don't know what to do about, and we usually tell it cannot be treated, but maybe it can. And together with Mr. Litvinchuk, we made a presentation on such cases. Occlusion of central retinal vessel can be treated, and there are new methods, laser and surgical methods. So our study was to look at the clinical efficacy of the surgery of the BRAO and central occlusion, retinal occlusion. 3 cases. In 2 cases, there was a partial embolism, and in 1 complete embolism of the central retinal vein. The duration from 72 hours to 30 days, and the embolectomy was done in 3 patients. So I would like to hear what you think about this surgery. This is my first surgery. I can see embolus. I want to excise it. And we lost the video. It's back. I'm using 23 gauge scissors. I want to squeeze it like a parrot usually does when trying to eat a nut. Well, I'm not succeeding. I'm thinking what to do next, because I'm not succeeding in getting through the wall of the vessel and get the embolus out.
Це йде вже по кругу трошки. О, а це? О, це воно. Вроді би просто, вроді би його треба
It
захопити.
seems like it's simple. You just have to catch it and make a cut, but it's difficult because it moves a lot, and we were also afraid of bleeding because we are cutting through the retinal vessel, and it can bleed severely. Later on, I wanted to pull it towards me with pincers, forceps. I'm not succeeding too much in that. And this embolus is calcified. And we decided to cut the vessel wall and to see what happens.
Пішла кровотеча і ембол
So
вийшов.
hemorrhage started, and the embolus got out to the vitreous cavity. The bleeding was not strong, and it subsided on its own during some 40 seconds. So we can stop the video now.
Перші враження.
So first impression, the instruments that we are using are too rough to work on vessels. For vessels, we need smaller instruments. But -1 fear because the bleeding subsides on its own, and it's not necessary to get the embolus out. It's not a bad tooth. It's enough, just to cut through the wall of the vessel, and it will be pushed out. So to me, embolectomy of the central artery is just cutting through the wall. And whether we have good instruments in order to do this efficiently, we do not have such instruments. We need to manufacture that, to design it and manufacture that. But so far, we don't. So we decided to communicate. We started to communicate with our colleagues, and we looked at the difference between the outcomes of surgical and laser embolectomy. Laser surgeons have very high precision instruments. They are afraid of bleeding, but for bleeding, we are there for bleeding. So that's not a problem. We will clean up, so to say. So in embolism, we need to have this symbiosis of specialists. So they can do it, and we will support them in case of bleeding, and we will be supported by them because they have better, finer, more accurate instruments. So this is our combined work with Stas Saxonov, and you can see that in the majority cases of embolism, results improve. If it's a complete embolism, we don't have that improvement, but our patients were from 1 day to 30 days. So we are disproving one old myth that embolism is not treated. It can be treated, even if it has been several days or even several weeks. It's possible to treat embolism. Thank you very much.
Дякую, Микола Миколаївич.
Thank you.
Тоді Яна Сір.
In that case, Yana Sirman, clinical cases of surgical treatment for submacular hemorrhages of various etiology.
Добрий день, шановні колеги.
Good afternoon, dear colleagues. I'm proud to present clinical cases of surgical treatment for various origin submacular hemorrhages.
Субмакулярний крововилив, як відомо, це
As you
накопичення
know, submacular hemorrhage implies accumulation of blood in the central area of the retina, which originates from choroid vessels and may be located between the neurosensory retina and pigment epithelium, or between pigment epithelium and the choroid. This causes rapid vision loss. The most common cause of submacular hemorrhages are AMD, SNVM, trauma, or hypertension. Negative effect of submacular hemorrhage is caused by the following factors. First of all, it's the mechanical barrier between the pigment epithelium and neuroepithelium, which implies metabolic disturbances in the retina. Secondly, ions of iron are toxic to the photoreceptors, and contraction of the blood clot causes mechanical injury to the photoreceptors. High-volume subretinal hemorrhages may lead to necrosis of the retina. We have operated 3 patients between 35 and 85 years with submacular hemorrhage of traumatic origin caused by age-related macular degeneration and hypertension. Emulsification of the cataract with IO lens implantation was performed, as well as vitrectomy with 25-gauge instrument with pneumoretinopexy and prourokinase. The techniques of phacoemulsification and vitrectomy was standard. Recombinant prourokinase was administered via a 40-gauge cannula. The dose was 0.1 to 0.5 milliliters, corresponding to 1,000 to 3,000 of international units of the fibrinolysis of the TAP. Our first patient was sought medical care for severe contusion causing sudden vision loss. The patient presented 15 days after the injury. At time of examination, her visual acuity was 1 on the left eye and 0.01 on the right eye. Central scotoma was seen in all meridians. The patient was operated on 16th day since vision acuity loss. As you see on the photograph, 1 month after the surgery, her visual acuity was 0.5. No scotoma were seen and the perimetry was restored. Our second case is a 67-year-old female patient who sought medical care after sudden vision impairment, after tilting forward. At time of administration, right eye visual acuity was 0.02 and left eye visual acuity was 1. She was operated on the 8th day after the visual acuity loss. As you see from the photograph, you can see the ophthalmoscopic picture and her vision after the surgery. We can see improvement of her vision. OCT is really decent 1 month after the operation. Our third case is a patient who sought medical care. She is 85 years old and she sought medical care on the 2nd day after visual acuity impairment. She has a history of dry AMD on the left and scar-related AMD on the right, associated with several years history of diabetes mellitus. Central scotoma was also identified by perimetry. The patient was operated on day 8 after visual acuity loss. And as you can see, 1 month later, we received insignificant but the improvement of visual acuity to up to 0.08. But as you can see, recurring submacular retinal hemorrhage the hemorrhage recurred because the patient refused further therapy. In all cases, the surgery went as planned without any complications. Adherence of the retina was achieved. And the hemorrhages were not very massive. All patients noted improvement in visual acuity. Thus, our results indicate that the surgical procedure is associated with good functional result, improves visual acuity, and decreases dimensions of the central scotoma. The surgery is safe for the retinal structure, and long-term efficacy can be assessed by longer follow-up. Thank you for your attention.
Всі питання після всіх докладів.
The questions may be asked after the last talk. And our last talk for this session will be presented by Nicholas Labauri, endogenic endophthalmitis.
Thank you so much, Dr. Karol. And I'm very sorry to be late for the session. Okay, so it's a long presentation and I will try to fit in the 7 minutes. We are talking about endogenous fungal endophthalmitis, and it's a very special scenario because it's not just a fungal endophthalmitis exogenous, because it differs a lot. In these particular cases, we need to treat patients systemically as well as locally. I mean, the intravitreal injections and so on. So it's very rare. It accounts about 2 to 8% of all kind of endophthalmitis cases. So what about the risk factors? In risk factors, especially we have the drug abuse, and it could be the indwelling catheter, as well as there is some special conditions like diabetes mellitus or history of receiving the immunosuppressive drugs. So the diagnostics, when we take the samples from the eye, we have several methods how to diagnose this disease. It is a PCR test. It is a bacterioscopic test and the bacteriologic test. So in bacteriology, we need a lot of time, and that's why in most of the cases, we are treating the patients, empirically. The bacteriologic examination, it takes about 2 weeks, but bacterioscopy, which is a Giemsa stain, it takes about several hours. The PCR test is very fast and very efficient, but it actually doesn't give us information about the sensitivity of the antibiotics. About the intraocular samples, the ocular manifestations are very numerous because it could be the anterior chamber inflammation, posterior chamber inflammation, it could be the vitritis, and the condition is called the endophthalmitis when it comes into the vitreous cavity and it inflames the vitreous cavity, posterior segment and anterior segment as well. But until it is limited into the chorioretinal tissue, so we call it fungal chorioretinitis, not the endophthalmitis. So once it comes into the vitreous cavity, of course, it is called the endogenous endophthalmitis. So what about the treatment? We usually use the oral voriconazole, which is very expensive treatment actually, but in our country, we use the fluconazoles from azole groups, and also we use the Polyenes. We don't use the Polyenes for intravenous injections. We use Polyenes for intravitreal injections like amphotericin. So the dosage is very important because especially the amphotericin is very toxic, and it has to be 5 to 10 micrograms in 0.1 cc, unlike to voriconazole, which is about 100 micrograms in 0.1 cc. There are special clinical manifestations which is characterized for candida endophthalmitis, which is a fluffy white balls in the vitreous cavity. And once we are doing the diagnostic vitrectomy to take the sample from the vitreous, once it is seen, we can just assume that this is patient for the candida. As well, we know that the candida is the most common cause of the endogenous fungal endophthalmitis. So this is the first patient. I'm just going to show you a few patients from my practice. And this is a patient with candida endophthalmitis. And you see here, there's a severe vitritis over here. And also on the left side, there is an inflamed vitreous with PVD, not total PVD, but partial PVD. So in this case, what we are going to do, I just want to forward it, because it's a long video. So what we are going to do, because the inflammation is everywhere in the vitreous cavity, sometimes we are getting the inflammation which is concentrated in one particular area. In this case, it's just diffuse vitritis. That's why we are doing the one port sample taking the sample. So we are disconnecting the aspiration line and connecting the syringe. And there is only one trocar. We are going inside, and it's a blind vitrectomy and aspiration. So we are aspirating manually, of course. And once we are getting about 0.5 cc of the fluid, this is quite enough just to send for bacteriological study as well as bacterioscopical study. So can I get it in the full screen? Because I need to forward this. Могу я получить это полностью, чтобы она приходила вот так. Full screen. Что я мог перемотать видео, чтобы мог перемотать видео. Да. Нужно вроде перемотать видео. Да, здесь. Okay, so. Okay, so once we have taken the vitreous samples, then we are proceeding with a regular vitrectomy, with a 3-port vitrectomy. So there is nothing special. Actually, this is the case with the intermediate inflammation. So we are going inside just doing the vitrectomy. We have to be very careful with the posterior vitreous. It has to be detached, not in all the cases, but when we have the partial PVD, also we need to attack the central vitreous part where the posterior vitreous is attached onto the optic nerve, and we have to separate it. And you can see in this video this white fluffy balls, as I mentioned before, which means that it's indicated in it indicates to the candida endophthalmitis. So in this case, once the infusion is on, so we are not collecting the sample. Why is it so? Because in the infusion line, we already have some amphotericin B, and the results could be false negative. So the next, it is just a view of the same patient after the surgery. And this is another case. There you can see the hypopyon, and you can see the vitritis, the inflammation in the vitreous. And also through this vitritis, you can see the chorioretinal lesion. So it comes through this posterior hole, and this inflammation spreads into the vitreous cavity. So the same thing here, we had, just like in the previous slide, we had some concentrated inflammation into the central vitreous. That's why our goal is to go inside there and aspirate and take sample from this particular area. So here, so we do 2 trocar insertions as the first time because we need the light. We go inside directly into this lesion, into this vitreous lesion to aspirate. There is no infusion on in this particular moment, and we are getting the hypotony, of course. So once we got the enough volume of the sample, and you can see the hypotony, then we are moving to the infusion line to reinflate the vitreous cavity again to get the pressure back, and we are putting another trocar, and we are proceeding with the routine vitrectomy to do the vitrectomy. And it's very important also when you do the vitrectomy to always depress and see the periphery to not create any retinal break. If there is any retinal break, you need to treat with a laser or with the cryopexy. And now once the vitreous is removed, you can see the chorioretinal lesion, which is very near to the fovea. And also you see this, the white snowballs here, which indicates to candida, endophthalmitis. And at the end of the case, of course, we are injecting here the two things because we don't know exactly the diagnosis. We don't have the results from the labs yet. So we are injecting the amphotericin as well. We are injecting the vancomycin to cover both the bacteria and the fungi. So scleral depression is very important at the end of the case. So you can see after the surgery, once everything is healed, there is no hypopyon. And of course, once again, to go through this case, here was a before surgery. It's a few days after, but still the chorioretinal lesion is active, and we are maintaining the systemic fluconazole for this patient until this disappears. It takes quite a long time, about 1 month, and once it's completely gone, actually we saved a little bit of fovea, and we are still having the very good vision. This is another patient. Actually, this is a patient immunocompromised having AIDS, and we have this aspergillus case causing the endophthalmitis aspergillus, and you see that it has a little bit different clinical manifestation. It has the more peripheral chorioretinal lesions, and it has a much less vitreous inflammation. So here we are showing how we are getting the anterior the sample from anterior chamber. It's a 27 gauge needle going inside the hypopyon and aspirating the fluid from anterior chamber. And you will see that we are collecting quite a few volume of the fluid, which is sent into for the PCR test as well as for bacterioscopy and bacteriology. But the sample taken from the anterior chamber usually it comes a negative results from bacteriological treatment. So, and we are injecting the amphotericin B. This is day first when the patient appeared. So once the patient appears, so we need to react as soon as possible because we don't have too much time. So as soon as you treat endophthalmitis, it's like any kind of other endophthalmitis. As soon as you treat the patient, as better result you get. So, and this is the same patient a few days later, because it takes few days until patient gets some clearance from the local governmental reimbursement, and now we can do the surgery. It's a phakic patient. Of course, we do not touch the lens. We are not doing the combined surgeries in endophthalmitis cases. So, and you can see this patient is having the posterior synechia as well. So the vitreous is not that much inflamed, and whatever the injection we have done, so this injection actually reduced the inflammation during these 3 days before we have taken the patient to the surgery. And we are trimming the vitreous up to the base. So there is not necessary to trim all the vitreous base, because this is somehow the inflamed retina, and you may create the breaks easily, and you need to accompany it with a gas. And if the breaks are many and they are large, then you need to use a silicone. Also, it's not a good option. That's why you have to be very careful to not to go to the retinal periphery very aggressively and not to shave the vitreous space. So this is a very important step, because you need to depress, like any other vitrectomy cases. When you have the retina on, you need to depress and see whether you have some retinal holes or the breaks to treat them properly, and then we are injecting the antibiotic. So this is the case, the same case after the surgery. Of course, there is some cataract also, and once the inflammation is gone and we control the infections, they will do the cataract later on. Just very quick 2 slides. This is another patient here before we have done the vitrectomy, and this was a candida case as well. And this patient is having here just behind this vitreous lesion, we are having the chorioretinal lesion as well. And you can see the same patient after the vitrectomy. Of course, there is some growing of the retinal tissue, and because of the vision is still good and there is no metamorphosia, we are just watching this patient, observing. If some symptoms will appear, then we'll take for the LM pill. Just as a home message, of course, as soon we treat and as soon we diagnose a patient, of course, as better results we have. And the vitrectomy is necessary when we have the inflammation into the vitreous cavity. If we are just having the endogenous chorioretinitis and not the endophthalmitis, of course, those patients are treated only systemically. But if we have the endogenous vitreitis and endophthalmitis, this patient is required to be treated with a vitrectomy plus the systemic antifungal drugs. And thank you so much for your attention.
Дякую, Ніколас. У нас
Thank you
буде
very much, Nicholas. We'll be having another talk here. The speakers have only just arrived from the operating theater. So our next speaker, our first experience of using brolucizumab in treatment of NAMD. Good afternoon, colleagues. As you know, brolucizumab was registered in Ukraine at the beginning of this year. However, our first chance of actually using it came at the end of May this year.
Відповідно, пацієнти, яких ми використовували, в першу чергу звернули увагу на тих, кого ми вважали поганими.
Hence, we focused on patients whom we considered to be poor responders to prior treatment. I would like to demonstrate a number of cases. This is the patient's retina. It is highly discussable whether the administration is warranted or not. The patient has been consulted in a number of clinics in Germany. He has had multiple intravitreal injections and no major improvement has been achieved. But we decided to administer brolucizumab. Top slide shows the picture prior to administration, and below you can see the improvement from 0.02 to 0.07. Anatomically, the result is quite optimistic, but as the second eye is 0.07, we can consider this effect quite promising. This is our second case. You can see the retina, and the patient has a history of multiple aflibercept injections. You can see the top section through the macular area prior to injection, and the second OCT is slightly above the macula. You can see high detachment of macular epithelium. This is what happened 1 month after the surgery. There was no improvement in visual acuity. It is still 0.08. But in terms of anatomy, the response is okay. Our next case, a patient has been treated since 2019. He has received multiple intravitreal injections of anti-VEGF medications. The patient has been checked for diabetes and it was negative. You can see OCT after multiple doses of Eylea. After brolucizumab, it took 1 month to achieve what you can see on the slide in the bottom. There was also a significant improvement in visual acuity. Our next case, the patient's uncorrected visual acuity was 0.08. History of multiple intravitreal injections of bevacizumab and aflibercept. Kenalog photodynamic treatment has been performed in the past as well. This is her OCT prior to injection and 1 month after the injection of brolucizumab. Anatomically, the result is quite positive, but however, there was no improvement in visual acuity, obviously. As you can see, in all cases, our result was good in terms of anatomy. So what would have happened had we started brolucizumab earlier? I don't know. We need to follow the patients for a longer time, and we need to try treating non-responders with this drug at an earlier stage of the disease. If we focus on pharmacokinetics, probably this is the answer to this question. After injecting anti-VEGF intravitreously, the drug may move anteriorly into the anterior chamber angle and posteriorly, either through the aqueous humor or so, and further either through the iris or through the retina. Internal pores of ILM measure 10 nanometers. Pores of outer limiting membrane are 6 nanometers. Pigment epithelium pores measure 2 nanometers. Molecule of brolucizumab measures 2 nanometers in diameter. This is what determines the migration of brolucizumab molecules in the eye. For now, we are optimistic in terms of future use of this drug. And now we have Adam Savinsky. So then, Tatiana Smal, blind eyes, challenge for the surgeon or challenge for the patient? You have 7 minutes for the talk. Good afternoon, dear colleagues. So, blind eyes, is it a verdict for the patient or for the surgeon? Can a surgeon disqualify a patient for the surgery? The reasons are numerous, including lack of light perception. But is it true that our patients do not actually see the light? Case number 1, severe injury to the only sighted eye. A patient was admitted on the second day after traumatic injury with avulsion of right eye membranes. 7 years ago, the patient was operated for glaucoma and cataract of the same eye. The left eye is blind because of glaucoma. The patient has a history of diabetes mellitus and hypertension. Examination revealed incorrect light perception, minor hematoma in the palpebral hematoma, blepharospasm, and other signs of traumatic injury to the eye. Of course, the artificial lens was gone. Thickness of the iris is in the iris, blood clots are visible. Surgical care, initial surgical care was performed, and in a couple of days, the patient complained about impairment of the vision, hence urgent surgery. Please note, there is light in the port, and we cannot see the light. I checked several times whether my light was actually off. This is how thick the hemophthalmic injury was. So we had to go through the anterior chamber. Now that the port is in order to achieve irrigation, I had to liberate every port separately. On this video, you can see the gray retina, and the rest are blood clots, which are thick and firm. The clots began because of traction. I apologize for the poor quality, but you can see I'm removing a clot from below the retina. Massive hemorrhages were present in the eye of this patient. Here the picture is of poor quality, but you can see that the central area is free and it has been flattened with PCFL. You can also see subretinal hemorrhages in the periphery. Unfortunately, I had to perform almost complete retinotomy and then laser coagulation of the retina. This is a photograph of the same patient 10 days after the surgery. His vision is 0.06. OCT of this patient. The quality is poor, but we performed OCT in order to establish further strategy. Unfortunately, after removal of silicone oil, severe rapid decompensation of the cornea occurred with thickening of the scar, thickening of the cornea, and partial peripheral neovascularization associated with hypertension up to 20 to 40 millimeters. Despite treatment, the cornea did not improve, hence go-through keratoplasty was performed, considering that the patient's eye was, this was the patient's only sighted eye. I'm also grateful to Igor Yaroslavovich for helping us out in this case. There is a video here. I would like to show you the surgery. The video is called keratoplasty. I apologize for the interruption. I wanted to show you the changes in the cornea. As you can see, this is what the cornea looks like, but this was the patient's only sighted eye. We explained everything and they agreed that the surgery gives them some tiny chance. After removal of the cornea, and the procedure was very special in that we had to order specific sort of type of tools of smaller size. Here you can see the fibrovascular membrane, which appeared in the iris plane. There were hardly any remnants of the iris here. And this is the post-operative situation. After the surgery, and let's go back to the slides now. After the surgery, the patient was able to see objects. I'm struggling to switch my slides. When the patient appeared for the last follow-up, we identified paramacular subretinal structure, which provokes retinal detachment in the retinal area. It's not our intention, but this is what the patient insists on, hoping to see again. Our second case, massive subretinal hemorrhage. History of wet AMD, polypoid vasculopathy with choroid neovascularization of the second type. The patient's surgery was offered immediately, but the patient consented 2 weeks later. This is a 61-year-old patient who sought medical care for rapid eye vision deterioration on the 4th day after intraocular injection of Hemase. Diagnosis: hemophthalmos, retinal detachment with subretinal hemorrhage, immature cataract of the left eye. Surgery was offered, the patient refused, but returned 2 weeks later with even worse vision deterioration. This is the surgery. As you can see, there are changes in the vitreous. There are huge bubbles of detached retina. Upon retinotomy, we had grayish fluid, brown and gray fluid. After partial destruction of the retina, we saw a huge structure around the macula. So we had to perform the retinotomy and to remove subretinal clots, which were very difficult to remove. And now you can see a thick membrane. In terms of thickness, it was very thick. And I thought this membrane would take all the pigment epithelium with it. So this is the end of the recording. You can see the membrane is difficult to remove. At the moment, the patient's vision is 0.1. This is her fundoscopy, and her OCT in the macular area is not bad. So despite the loss of vision, especially if it's the only sighted eye, it is not for the doctor to decide whether the patient will or will not see again. So everything that depends on us has to be done in order to give even the slightest chance to see to our patients.
Thank you. And this is our last presentation, and the resection of hemangioma using high-frequency welding, welding in Sturge-Weber syndrome. Hello, dear colleagues. Can I see the presentation, please? You're supposed to have the presentation, but if you don't have it, I can give it to you again. Let's see. Dear colleagues, now I would like to offer you endoresection of large choroidal hemangioma in patient with Sturge-Weber syndrome presentation. And what is a Sturge-Weber syndrome? It's encephalotrigeminal angiomatosis is another name, rare disease that affects newborns, 1 per 100,000. It's a malformation, vascular malformation in the area of the first and the second pair of trigeminal nerve innervation. It's the trigeminal nerve. And subsequently, there is a 50% risk of developing brain lesions, angiomas of choroid. So the frequency of hemangioma of choroid is about 50% in this category, in this group of children. Choroidal hemangioma is benign, slowly developing, not life-threatening, but exudative detachment, hemophthalmos might develop, and there might be secondary glaucoma development. This is the case. A girl who came to us, born 1996, with complaints, problems, visual acuity in the right eye, and you can see the vascular malformations, and also the light perception was poor. So from her history, we could see that she already came to us, and there were fluorescent angiography and other observation tests. So choroidal hemangioma diagnosis was there, but sometime later, when her mother asked whether it's a life-threatening or not, they learned it's not, so they just went home. So during the 3 years that they were just at home, did not do anything, you can see the changes. So you can see the vascularity and the area affected and the total retinal detachment developed. So the visual acuity decreased. We were thinking of some time of treatment with such a clinical picture. So no photodynamic, not laser therapy, no other therapies would have been efficient in such a huge lesion. And if we affect the tumor with laser or like irradiation, uveitis, very severe uveitis might have developed. So Considering that, and the resection was offered. So we looked through the literature, we didn't find any information about somebody doing that, but in 2019, Barbara Parolini presented about the resection of small hemangioma. It was about 1.5 millimeters. And exudative retinal detachment was the indication to the surgery. She declared actually that was done for the first time because she didn't find any literature data about that. So this is the surgery that we are offering to you to watch. You can see hyaloid membrane attached very strongly to retina. So we had to do the dissection 360 disease and excise the bleeding, and then we are pushing off the retina with PFCL to the direction of the choroidal hemangioma in order to approach it. And before the excision, tumor excision around it, we do the electrical welding of choroid vessels to prevent bleeding, and we took the piece of the tumor just to look at the histology, to look at the structure, and then piece by piece we removed all the tumor. But by the end of the operation, as you can see, we had quite a big bleeding from the feeding vessel. But bimanual technique was used with welding. We were able to stop, and the residual pieces of tumor were successfully removed, and the surgery was completed with silicone all-term tamponade, and the retina goes back to place, then laser and silicone. So histology from the diagnosis of capillary hemangioma, and the results, long-term results, and 5 months have passed. You can see attached, retina attached, and the visual acuity is up to 0.1, and the globe was preserved. So we achieved both anatomical and even functional result in a patient with choroidal hemangioma in Sturge-Weber syndrome patient. Thank you for your attention. Dear colleagues, so now we have shown all the presentations except Adam's presentation. If you have any questions to presenters, please, you're most welcome. We do not hear. The microphone is not engaged. Microphone is not used by the speaker. No translation is possible. So if we think about the instrument, how to work on arteries, on vessels, I believe it should be a very thin 25 gauge knife. But we have to order it. In Russia, why? Russia, it's either Russia or Switzerland that we can get it from, and they are manufactured just in those two countries. And in 90s, we used to manufacture such knives in Kiev, but that stopped. We are no longer manufacturing such knives. If I may, I just wanted to ask why, if we have subhyaloid hemorrhages, why didn't you use laser technique for drainage? Well, they were under the hyaloid, and even on OCT, you could have seen that it was under the hyaloid. Microphone is not engaged. So what was the cause for such bleedings, for such hemorrhages? Microphone is not engaged.
Я перепрошую, якщо можна так. Якщо був травматичний, там був
Okay, if it was a trauma, a choroid was ruptured,
він здавався як відкладення фібрину.
it looked like fibrin deposits.
А що означає гіпертонічний крововилив?
What do you mean by hypertonic bleeding? The other person is not using the microphone.
При гіпертонічній хворобі
In hypertension, bleeding happens like macroaneurysm, arterial or venous macroaneurysm, or Valsalva syndrome also might lead to such things.
тобто це
In other words,
є симптом субретинальний крововилив.
there is subretinal hemorrhage, just the symptom, and you just did your procedure that you described.
Якщо запитань не буде,
If there is no other questions, we might complete this session at that. And thank you once again to all the presenters.
valve implantation, making in my own modification because of the refractory glaucoma in pseudophakic eyes after posterior.
Ну і зараз нас підключили після вітректомії, задня вітректомія. Оце глаукома. Що стосується глаукоми, всі ви хірурги, які оперуєте в серйозних випадках ретинопатії діабетичної, це може бути тромбоз вени, травма для ока, то що тоді робити, коли дуже високий тиск, 50, 60?
Another way of outflow. I like Ahmed valve. You see the two models. First, on the left is the model was designed to put it into the vitreous cavity. You see that it has a special adapter which changed the direction of the tube, and anterior model. Why was the reason of such modification? In my hands was post-operative complication. Because I'm a first posterior segment surgeon, I start to make an implantation of the model designed to the posterior segment surgery. But 2 weeks after the surgery, in most cases, I've observed the erosion of the conjunctiva. People has pain, a lot of pain, and most of the models I have removed until I start to think to do something else. Another reason is progressive corneal decompensation caused by an Ahmed valve tube which was positioned in the anterior chamber. Sometimes it happens. So what do I first? In the first case which I did, I removed this adapter and included this tube once again to the vitreous cavity. Methods of Ahmed valve implantation. I have 2 secondary implantation. First group was a removal of the adapter, introducing the tube to the vitreous cavity once again. Removal of the tube from the anterior chamber, creating of the entry sites via sclera, and introducing the tube into the vitreous cavity was another secondary implantation. And by primary implantation is the positioning of the tube of the valve, which was designed to put it into anterior chamber to the vitreous cavity. And this is the etaps of implantation. I usually create a intrascleral tunnel 4-5 millimeters long and 4 millimeters from the cornea in creating entry sites. And by this entry sites, I introduce the tube, which is positioned behind the lens. But at the end of the surgery, when you have dilated pupil, you have to see the tube. It can be positioned in centrally or peripherally. And the results, 20 patients, 21 eyes. 1 patient was operated on bilaterally. I made 4 eyes where I did combined surgery, PP with Ahmed valve implantation. In 2 eyes, I removed the adapter and secondary make implantation of the tube. In 4 eyes, I removed the tube from the anterior chamber and put the tube into the vitreous cavity. And the most in the 11 eyes, I introducing the tube into the vitreous cavity. And this is a short video, combined surgery. Now I'm removing the silicone oil. And I removed the tube from the anterior chamber because of the corneal decompensation. I'm creating intrascleral tunnel. I remove this tube and introducing the tube via entry site into vitreous cavity. And this is the end of the surgery. So switching the conjunctiva finishes the surgery. Results, I start from the complication. Transient hemorrhage to the vitreous cavity was observed in 12 eyes. Post-operative hypotony, mainly after combined surgery, was observed in 14 eyes, but it has gone for until the next control. It's after 7 days. This is very important. No effect of IOP normalization in 2 eyes. First eyes had very high pressure, and the patient has psychodestructive surgery. The pressure was normal for next 2 months, and after this, the pressure was the peak of the pressure to 60. I introduced the tube into the vitreous cavity. There was no change in the pressure. So I exchanged the fluid from the vitreous cavity, and after this, the pressure normalized. And the second was positioning tube under the choroid. So if you use such technique, you should see the tube behind the lens. Transient IOP in 6 eye, you can remove it when you make a massage. And conclusions. This modification gives you a stable normalization of the IOP, allows to avoid post-operative complication, typical, such as erosion of the conjunctiva or corneal decompensation. Possibility to check the patency of the tube is very important, and measurable economic benefits. Because I'm working only privately, I'm thinking about my money, my patient's money, and we know that the Ahmed valve, which is designed to the anterior chamber, is cheaper than the posterior segment. And it's useful when the anterior chamber is shallow. We have sometimes the eyes after posterior vitrectomy surgery with silicone oil endotamponade. The anterior chamber is very shallow. The pressure is 60. We cannot do nothing. And conclusions, my model of choice is Ahmed valve designed to implantation for anterior chambers, anterior chamber, but the tube is positioned to the vitreous cavity. If you are interested in this information, you can read my article. It was published in 2010. And thank you for your attention.
Thank you very much for interesting introduction, and it's really a very unusual technique of putting the valve in the vitreous body. So in the sake of time saving, we will skip questions, and if we'll have time at the end of the sessions, everybody are welcome to ask questions. We will be happy to answer. And I'm happy to introduce the next speaker, our guest from Georgia, from Tbilisi, Nikozas Lavodi. And he will give very interesting presentation about intravitreal torsional phacoemulsification of the drop nucleus. Welcome.
Thank you so much. Thank you so much, Dr. Andrei. Indeed, it was a very interesting presentation, Dr. Adam, and I have a lot of questions about this by the end of the session. So here is nothing special. We are talking about the luxated lens crystalline, and we use the term luxation because it is when the lens crystalline is totally moved into the vitreous cavity. So we have different reasons. So it differs, the term differs, luxation differs from subluxation, because subluxation means that it is just some part went to the vitreous cavity and we can manage this complication from the anterior segment. But when we have the total luxation of the lens crystalline or the IOL, of course we need the vitreoretinal surgery. And at the same time we are talking about to think about the aphakia correction and putting the lens. And as I already mentioned at the beginning of the session, there are many different methods how to handle these cases. And of course, we know what are the reasons of the luxations. It could be the trauma, it could be exfoliation syndrome, it could be a combination of those symptoms, it could be intraoperative complication like a PCR during the cataract surgery. And there are few congenital diseases which could be associated with the luxation of lens crystalline. And of course, the complications, what are the consequences of the luxation of the lens crystalline. It could be the uveitis, it could be like a phacoanaphylaxis, it could be the lens particle glaucoma, it could be the retinal breaks and the retinal detachment and cystoid macular edema. Now, of course, when we are planning our approach, it depends how bigger is the luxated lens crystalline. So it's a 1/3, 1/4, 1/2, or it's a total luxation. And of course, first of all, we need to think about not only how to remove the lens crystalline and remove the vitreous cavity, but also to correct an aphakia, to fixate an IOL into the iris, onto the sclera, or into the anterior chamber. In this particular case, I'm just trying to show you the way I'm doing the correction of an aphakia as well as removal of the luxated lens crystalline. So this is a patient, as you see on the B-scan, there is a luxation of the lens. It's a total lens luxation, and the retina is detached. And of course, the patient is having aphakic correction. So, oh, it's coming, I think, here. So, of course, my preferred technique is it's fine. So my preferred technique is to use the intrascleral fixation, and here there are many different approaches as well. So I'm using the original Chariot technique, and this is the 25 gauge MVR knife, and I'm doing the radial cuts through the sclera into the sulcus region. Of course, first I'm removing also incarcerated anterior vitreous. It's very important. And before I proceed with the total vitrectomy, posterior vitrectomy, and the lensectomy, of course, first I'm doing the IOL suturing, because the eye is firm. I have the vitreous inside, so it doesn't collapse very easily during the surgeries. That's why once I'm done with the anterior vitreous incarceration, then I proceed with the IOL fixation. And I use the special forceps to grasp and regrasp and externalize the haptic. And once I externalize the haptic, of course, I have the scleral tunnels. We need to open here the conjunctiva differently from the Yamane technique. And once both haptics are externalized, then I'm using the same forceps. It's a special designed forceps. It has just grooves inside the jaws, and grabbing it and pushing into the tunnel. So this is a nice technique, because in this maneuver, push and pull maneuver, you can centralize the lens. And at the end of the suturing, of course, you have stretched haptics. This is the main advantage of this technique to compare to other techniques like a Yamane technique, because during the Yamane technique, you're having the relaxed haptics, and you have more chance for the tilt of an IOL or the posterior location, etc., etc. So once I have done all this anterior works, and I proceed with the posterior vitrectomy and the lensectomy. So here is nothing special, it's just a vitrectomy. Okay, I use, when I know that there is no PVD, I use a triamcinolone to stain to better visualize. I do the PVD first, I remove the vitreous. I try not to shave the vitreous base aggressively, because it may cause more retinal breaks. You have to be very careful. And once you have the total nucleus displacement, so you need to know that there is a capsule which prevents your lens from the phacoemulsification. So first you need to remove the capsule by the vitreous cutter, and then sometimes I use the PFCL, but it's not necessary to use it all the time. And here you use a 20 gauge MVR blade, is cutting the sclera into the pars plana region, and I use the same phaco for probe. I always use the Constellation machine with a combined setup. So there is only one knob to push, and of course you have the anterior segment surgery, and this is the same regular Ozil tip which I'm going through the sclerotomy, and I'm attacking the nucleus. So I'm getting the infusion through the infusion line. I'm closing the infusion which comes to the phaco probe, and here I use only the power, phaco power, and aspiration, of course. And you have to be very careful, because it's quite large. It's a 20 gauge, and it aspirates much power, much more than aspirates usual cutter. So you have to be sure that your tip is always occluded, and you have to be careful during your phacoemulsifications that you should not engage any vitreous coming from the periphery not to create a break. So once the lensectomy is done, then of course, very important step, as I mentioned on my previous presentation, is the depression, the scleral depression, and of course we are having sometimes the breaks even before the surgery, about 10 to 11% of cases when we are dealing with a dropped lens nucleus or the dropped IOL. So here I'm using the same tip to aspirate the PFCL, but it's not necessary to do. You can do it with a cutter as well. So I suture the conjunctiva, and I suture the 20 gauge sclerotomy. The rest is the sutureless. So then I proceed with the fluid air exchange, and everything is in a routine procedure. So here is another case, almost the same approach. So here, can't see it. Okay, so and here I will be using the Trypan blue to stain the capsule to visualize, to completely remove it before I attack with okay, so and it's almost the same technique, so it's nothing special. Actually, to show, then comes the scleral depression and the same thing, so it's just a phaco tip. And as a home message, as we know, so my approach is just to do the anterior retrectomies, and I suture the lens, then I do the posterior retrectomies, and I do the lens removal and fluid exchange just to facilitate the wound closures. That's it. There's no tamponade needed if there is no break. Thank you so much, and sorry to run out of the time. So I have to announce, Dr. Andrei from Kiev, he will be speaking about the dropped nuclear fragments, almost a similar article, and how to deal with the dropped nucleus fragments.
Yes, thank you very much. Thank you very much for very interesting. So technique is, yes, as you have told, I have a lot of questions for both, for lens removal and for lens fixation. For time saving, I will speak Russian, this will be faster. Итак, я прошу прощения, буду говорить на русском, потому что у меня это получится.
I'm sorry, I'm going to speak Russian because it's going to be quicker. Otherwise, I will not be in time. So what do we do as surgeons? When we do the anterior chamber surgery, if something is going wrong, and we'll lose something.
Нет, давайте какой-то один не работает. О! Итак, когда я начинаю...
So, when I start some kind of examinations, and when I do studies or research, so it's always interesting to me to see whether this is the topic that is interesting not only for me, but for other people as well. And I love to look at the National Library of American Congress. This is international library. 52 pre-reviewed articles are there presented. So very interesting. When you type drop nucleus in search, so starting from 1969, more than 700 publications are there, and the number of such publications is growing recently. The most interesting thing now, the publication that was in 2020, European Commission on Quality Control for Cataract Surgery. And so it's a 10-year study, 2008-2018, on drop nucleus. With regards to percentage, it's very little less than 0.1% bound. But in Europe, overall, there were 1,200 cases of drop nucleus in Europe. Looking further, so here we can see the lens remnants in vitreous. Lots of publications on that topic as well, and lots of publications about the tear of the posterior capsule. So what are the risk factors? Anything can be a risk factor. Of course, it's a human factor as well, but also zonuloeftin, capsular bag, crystalline lens. So a lot of conditions leading to misfortune, so to say. So how does that happen? Like, for example, like zonuloeftin can be broke, what needs to be in the anterior segment or chamber, but it moves back, but the whole lens or just fragments, something that does not need to be in the interior chamber goes there, like vitreous, for example. What to do? The most important thing, every surgeon, if it's an uncomplicated cataract removal, should have a plan A, B, and C, just to know what to do if something goes wrong. Different surgeons, different plan, so there is no universal surgeon. Almost it's one thing when there is one person responsible for everything. The other thing, if it's an anterior chamber, anterior segment surgeon, but in this case, he needs to have a vitreoretinal surgeon close by who would be able to join in to support. Number 3, there is just a surgeon with no support. So what to do? I need to tell you that every time that I visit international congresses like this one and others, I always try to get to this session, vitreoretinal surgery for cataract surgeons. So that's the title of that session I'm always very much interested in. I listen to the advice of my colleagues. So the overall conclusions, what is recommended by them, what we need to do. We have to know the technique of the anterior vitrectomy skills, and we need to complete our work in the anterior segment first, and we do not have to go to the posterior one. You don't need to try to get something from out of there, something that we do not see behind the posterior capsule. Please leave that to your colleagues. If you don't know this technique, they will do it much better than you can do it. So different situation, different plans. Number 1. Well, at least it's my plan. For example, posterior capsule rupture without vitreous loss, that's we can turn it into posterior capsule recess, and we can implant the same lens that we planned, and it will sit there wonderful intracapsular. If it's a loss of vitreous, so probably this tear is going to be a big one, most definitely a total or cross through everything. And in this case, probably we will have to change the IOL implantation strategy and use so-called optic capture technique when we implant the haptic to central camera, and we do the centration thanks to anterior capsularesis. And when the fragments of the lens are going to the vitreous, in this case, we stop our work and we refer to colleagues. So you can see posterior capsule tear, and the surgeon turns it into a capsularesis. It's quite a standard procedure. Good thing that it's no longer done routinely, because it increases the risk of cystic macular edema, but when it needs to be done, it should. And now toric lens is implanted. If you pay attention, toric lens is implanted in a capsular bag, and no problem here with using it. Moreover, there is a prevention of secondary cataract that is done at the same time. I need this video to be started. Posterior capsularesis was not successful. It turned into a total one, if we may put it this way. So I'm implanting 3-piece IOL. Optic goes into the posterior chamber, and haptics go posteriorly, and optics is going to be centered thanks to the anterior capsularesis. And this maneuver makes it possible to do a good centration. And there is no threat of IOL shift without subluxation. So anterior capsularesis is shown, it's glistening on the surface of the lens. You can see how it fixates the optics. If something luxates into vitreous, once again, we are completing our work. We put the IOL and refer to vitreoretinal surgeon. If we cannot do the anterior capsularesis and there is no zonuleucin, it cannot be used, then we move on to IOL fixation. So lots of techniques, lots of options, how we implant the IOL in anterior interior, posterior chamber, how do we do fixation to sclera, so on and so forth. The most to iris Yamani technique to our mind is the most interesting one. Yesterday, during this session, the surgeons were saying Canabrava technique. And I believe that Yamani showed his video in 16 and Canabrava is dated 2019. So I believe Yamani was the first and then Canabrava. It's all transconjunctival canalization and flange technique of fixation is used. So it's only scleral fixation is used nowadays. If you look into the PubMed that I love, if I'm trying to find the term IOL fixation, you will not find it fixation to the iris, no fixation in the interior chamber. So everything is about scleral fixation. Once again, the number of publications on scleral fixation, lots of that in PubMed. And here, if we talk about fixation of IOL outside of capsule, we always need to understand then one-piece IOL, especially C-loops with rigid haptics, is something that will have to make you cautious because they might lead to this uveitis, glaucoma, hyphema syndrome, because it contacts with the posterior iris and the pigment is washed out and the whole cascade of problems is shown here. So when we talk about implantation of such IOL, it's the best way to use so-called reverse optic capture method. When the haptic part of the lens is put inside the capsular rhexis and optic stays over the capsule, but maybe we have to do recalculation of the lens because it's going to be shifted a little bit anteriorly and the refraction can be violated. And scleral fixation is the most interesting to my mind. What's so interesting about that? So what's Yamani fixation is good because we are free to choose this meridian. The most important thing, it should be 180 degrees of one haptic element from the other one. So it's phakic eyes, intracapsular extraction with sutures and rigid pupil was here. So that's why iris retractors are here and the lens is implanted. And Yamani implantation with 2 needles is done. I have a little modification of that technique. If you look here, so we measure the location where the first tunnel is made, and on the needle you can see a small silicone stopper. It's just a piece of injector that we just cut off. So what's interesting about that, because when we insert the haptics and we externalize it, I'm not passing this needle onto an assistant. I don't need the third hand, so to say. I externalize it, I fix it with the silicone disc, and the lens goes far from the second haptics. So again, just to say the same, I don't need a third hand, a third arm. I externalize the second haptics. I don't like to make the flange and coagulate the first haptic element right away, because then we might have some challenges during centration. So when the second haptics gets out, then we do the coagulation, we do the flange fixation, and then we do the coagulation of the second haptic piece, haptics element. So that's how such haptic elements look like, subconjunctivally, and there is no irritation. This is the second one. So straightforward gaze, and you do not see the haptic elements, they are under the eyelids. It's a little different technique here. It's a modification of Yamani technique, and we need the video. When I'm saving the subluxated lens, it's a lens that's inside the eye, and we put it about 15 years ago, if not more. So decompensation of zonules of zinc, a subluxated lens, and you can see monofill 6.0 is used in order to do the lens fixation. And I'm passing on this suture using the haptic elements. So this is the same flange technique. Basically, we are getting this suture out through one of the haptic elements. We do the coagulation right away. We coagulate the suture. And then we will have enough length for centration. And the same technique is used for externalizing the second end of the suture. And there is kind of a suspension for the lens that we create. I think here it's very straightforward. Clear, understandable. The only thing that you have to insert quite a big part of the suture into the needle, because sometimes when you're getting the needle out and you lose the suture, and then it takes time to find it. Well, it's possible, but it's better to do it correctly. So answering the question, what do we do if we are losing, if it's a lost nucleus? Still, we have to complete our part of that surgery, and then we have to please ask the vitreoretinal surgeons. We shouldn't do that if we do not know this technique. Well, another 1 minute, because I would like to show you an unusual technique. Well, necessity is the mother of inventions is the name. So 15 years for the lens, and the lens subluxated. And at the base of the haptics, I needed to do a hole in the lens, and then using that to do the flange fixation, because the patient didn't want to change this lens, trifocal lens, and it was good for the patient. And the next. So I usually say we have to think about the future generations, multifocal lens size. And I'm just preparing the lens just in case. Maybe if we need to fix it in future, we shouldn't have any problems and we shouldn't do anything inside of the eye. But this is the lens with already prepared openings for fixation. Thank you very much.
І наш наступний доповідач. Cataract surgery in AMD patients, Andrei Grabowski. Dr. Andrei, is here. Andrei Grabowski is from Poland.
Sorry, no, it was changed.
Okay,
he already presented.
Okay, so we are moving to the next speaker. So,
do we have a next speaker?
Dr. Aliana Kubai, yeah, from Australia. So we are talking about the special design under your chamber lens, right?
So if you don't mind, I'll probably speak be much faster. And I'd like to talk about the advantages of using the angle-supported anterior chamber IOL in complicated cataract cases where basically the capsular support is compromised. And the reason for that, I realized that in Ukraine, currently there are no AC models available at all. I'm talking precisely, for example, about Alcon Company, Kilman Multiflex AC IOL, or Bausch & Lomb Company, 122 UV. They've got 2 models, LLC, but none of them available currently. And if you're in a situation, once you've got a lot of patients on your surgical list, and there are some patients 80, 90 years old, and you just got stuck facing this situation, so you don't have too many options. So if vitreoretinal surgeon, for example, not available, or if you don't have, or you do have a skills vitreoretinal surgery, or don't have a vitreoretinal equipment available, then basically I think it would be very useful for our cataract surgeons just to use these models. I know that it's a little bit different kind of opinion about AC IOLs, and I'm not advertising them like for every clinical case, and just saying it's just in case situations, and just in case situations when the cataract surgeon basically facing the situation that I explained already. Indications for placing AC IOL is going to be when capsular support for placement of the intraocular lens posterior to the iris is deficient, or the iris is normal, and the chamber AC IOL is quite deep. Options for placement of IOLs in this situation, like my previous colleague mentioned already, you could use AC IOL, you can use iris fixation IOL, you can use scleral sutured IOL, and also the procedure to tuck the haptic into the sclera with or without gluing. There are some relative contraindications as well, and they are if patient does have any corneal endothelial disease or iridocorneal angle damage, shallow anterior chamber, or some lack of substantial iris tissue. There could be some potential complications, but we have to keep in mind that those complications that most of the colleagues thinking right away, if you're telling them that, in this situation could be use AC IOL, there are some experience with those lenses that been kind of designed back in 1970s or 1980s. And I don't think, like I mentioned already, in Ukraine, nobody was using those more advanced AC lenses because they're basically not registered, they never been available, and to my understanding, our surgeons just don't have an experience of using them. And as you can see that the newer models of AC IOLs, they are open loop, such as a Kelman Multiflex by Alcon or Bausch & Lomb, for example, in different sizes, and they have shown decreased complications rate compared to those that been available back in 1970 or 1980s. This is the how Kelman Multiflex Alcon lens AC IOL looks like, and the Bausch & Lomb has similar design to this one. There are some literature on comparing different methods of fixations in these complicated cases. And some of them coming from American Academy of Ophthalmology, that they did meta-analysis on different type of IOL fixation in cases where it's a poor capsular support. And they discovered that comparing those different type of fixation, they didn't find that AC IOL, they're not inferior to any other types of IOL fixation in this group. And there are plenty of those reports available. And also I'd like to show that there are some world experts that dealing with these kind of IOLs, and it's independent opinion, and it's a world, famous names. Some of them, Dr. Brenner, who works like consultant for Alcon Lab, Genentech, and others. Dr. Kaiser, he's quite a frequent speaker, and he published a lot of scientific papers, on the topic. And Amar Agarwal, for example, from India, he's quite a prominent person in this area too. And what they are saying, for example, Richard Kaiser mentioned that he defends AC IOL, saying this is quite a safe technique, and the modern open loop Kelman style actually deepens the anterior chamber, and there is no accelerated endothelial cell loss that would be, associated with this lens. The other people, the world experts, saying pretty much the same, that Some of them saying that the serious complications, they are more frequent with the scleral and iris fixated IOLs, such as retinal detachment, hemorrhagic choroidal detachment, late onset IOL dislocation, etc. The main surgical technique. Once you're using this technique, it's much faster actually than to do, for example, scleral fixation. Like I said, when you're in a situation when it's plenty of patients, you got stuck with this case. So you can easily use extra 5 or 6 minutes. That's how long it takes to simply insert this lens. What you need to do, you just have to create a 6mm incision for this type of lens. You can just have to deepen anterior chamber, remove all the vitreous if it's there, and then inject, I don't know, in Ukraine we don't have myocol. It's something that you can enter into NC and it will constrict pupil immediately. I know that some surgeons here using pilocarpine, for example, from the ampoule, so you can also just inject in it and it will constrict the pupil. So pupil needs to be constricted for this type of technique, no vitreous there. And then don't forget to do peripheral iridotomy as well. And then basically you put in some viscoelastic into the anterior chamber. You're using spatial glide. A lens goes so easily, you know, on this glide into the anterior chamber, and you just have to position it properly and suture a couple of sutures, and it's all done. So it takes 5 to 6 extra minutes to complete the surgical case. I'd like to show you the surgical video, but unfortunately we double check, so it doesn't work. Any questions? Sorry.
There are a lot of questions. Thank you.
And now, зараз мені дуже приємно
Now I'm pleased to introduce our next speaker. It is Lyubomir Litvinchuk. He will speak online from Germany. Lyubomir, can you hear us well? Yes, I can hear you well. Can you hear me? We do not see you yet, but I suppose we will see you soon. I am connected. I can see myself and I can hear myself. Can you hear and or see me?
Любомир буде нам представляти.
Lyubomir will present an interesting talk about the use of bagging the lens technique to treat cataract and could you please confirm you can hear me?
Так, зараз ми бачимо вас.
Yes, we can see you and we can hear you.
Так, так, все гаразд. Чуєте ви мене, Любомир?
Can you hear me?
Щось пішло не так.
Алло, алло.
Так, бачимо вас.
We can see you.
Так, так.
Можливо, я себе виключу.
Maybe I will disconnect myself.
Зараз ми бачимо вашу... Ні, щось
Okay.
не так, ми бачимо якось...
Something is wrong. Somehow the screen is changing.
Star Wars. Зараз мене видно, чути?
Так, зараз все
Can you
гаразд.
see me and can you hear me?
Ні, знов той самий ефект.
Now we are dealing with the same strange effect.
Спробую перезавантажити.
I will try to reboot now.
Може ви зараз? Юрій Павлович. Ну так. Скільки це за 15 хвилин? То ми не... Дійсно маємо час на декілька
We
запитань.
do have some time for questions. Who is the bravest one to ask question? Can you see me? Can you hear me?
Так, зараз і чути, і видно.
Now we can see you and now we can hear you. So everything is fine. So good afternoon, Lyubomir. I would like to give my gratitude for your invitation, for the opportunity to take part in this conference.
Дуже дякую професору Новицькому.
I'm really grateful to Professor Novitsky,
Цю сесію
and it is really nice that this session is moderated by a former teacher of mine, Andrei Ivanovich Kovalyov, with whom I had the honor of working together and learning from.
доповідь я оголошу українською мовою, оскільки
I will
цільова аудиторія
speak in Ukrainian because my target audience is in Ukraine. However, the slides are in English, so our colleagues will be able to take part in this conference as well.
можете запитатися в
Andrei Ivanovich, could you please ask the audience who can expand?
будь ласка, в аудиторії, в слухачів.
Could you please ask the audience who can expand the abbreviation BIOL? BEIOL. Nobody can do that. Does anyone know what it is?
We can Google it for you.
Ні, добре. Це скорочена
This is an abbreviation for back in the lens.
Якщо хтось, вірніше, я думав, що хтось підніме руку, і я хотів
I
подарувати.
was actually hoping someone would raise their hand and they would get this book as a reward. So please pick someone from the audience whom I will be able to send this book on this new technique. In 2015, we performed a short study with intraoperative OCT, where we detected the position of lens after lens in the back technique. What we were interested in was the location of the capsule in relation to the lens and how it may affect the posterior cataract formation.
Більше ніж 95%
What I found was that in more than 95% cases, at the end of a typical procedure, there is no contact between the capsule and the posterior surface of the lens. We also rarely saw any contact with the square margin, which is supposed to prevent migration of epithelium onto the posterior lens. So our standard technique has some concerns. No, it is no secret that in many cases us, the surgeons, depend on manufacturers of lenses. And in many cases, it is them who tell us what to implant and how to implant that. When I see doctors who present some materials on back in the lens technique, I sometimes think these doctors, as well as me myself, are seen in a strange way. This is something difficult to understand, and there is some resistance that we experience. This resistance comes in part from unawareness of the technique and from
Моя мета не є повністю
and from lack of experience. So my purpose is not to overcome this resistance, but just to tell you about my own experience and my own attitude to this type of lens. Professor Marie-José Tessignon from Belgium, from Antwerpen, invented this special type of lens. It was patented at the end of the 90s, and the first publication, it's one of the most important ones, dates back to 2002. It's about human implantation of the lens. In this paper, she shows that the risk of posterior capsular cataract decreased significantly. As you can see, this chart shows the lens in the back and back in the lens techniques. This is the optical part of the lens, and there is a groove along it in 360 degrees. And between these two haptic elements, actually, we need to perform the double capsular axis of a specific dimension, 4.5 to 5 millimeters, and both capsular axes must be implanted into this circular groove. In this case, proliferation of the epithelium will be limited to the periphery and will never occur in the center. The second important paper came out after professor tested this technique on children. And since then, I suppose pediatric cataract was changed by 180 degrees. According to the last data, this technique allows to decrease the secondary opacities in the posterior axis, not just in the capsule. Anyway, the risk goes down to 4 to or 3%. 94 to 96 to 97% do not have this complication. In children, as you know, this proliferation may be aggressive. It may extend as far as to the vitreous. In case of posterior capsular axis, this may require retinal detachment and reoperation. The lens is implanted via the typical cartridge, and the technique is remarkable about the following. After 5 millimeter capsular axis, and after removing the lens, instead of filling the capsular bag with viscoelastic medication, only a puncture is made in the posterior capsule, and the barrier space is punctured. That is the space between the lens and the anterior vitreous. This is the place where hyaluronic acid is injected into. This is done in order to detach anterior hyaloid of the vitreous from the posterior lens. And this is a crucial point according to the inventor. This ensures by this way we remove the vitreous, and thus it will never go forward after the implantation, and it will never cause cystic edema of the macula. Precision in anterior capsular axis is very important, and there is a number of techniques. One of the techniques that we use implies calibrated rings. We also use the SACE system. It allows us to see the markings. I'm not sure if you will be able to show my video, but we can use the Minosis septo technique. There are also reports about using anterior and posterior capsular axis using femtosecond laser. I will show you a number of implantation techniques on a young child where no phaco is necessary. Hence, normal cataracts is being treated. We implant the ring.
Це є 5 мм, і він дає нам змогу точно провести капсулорексіс.
It enables us to perform precise capsulotomy. After that, the ring is removed. After that, we do typical cataract surgery. And after removing cortical masses, after removing the cortical masses, we puncture the posterior capsule. Viscoelastic is injected into this opening in order to detach posterior lens surface from posterior capsule from the anterior vitreous. Viscoelastic which remains in the vitreous, if it is not a combined surgery, definitely does not cause secondary glaucoma. After some time, it will just resorb. After this detachment, we perform posterior capsulotomy for surgeons who have performed this procedure. There is nothing very special about it. Everybody knows it is way safer and way easier than anterior capsular access. After that, we implant the lens, the IOL lens invented by Tassignon, Professor Tassignon. This is a very important invention in ophthalmology, at least in my point of view. The lens must be placed beyond the iris. After that, something difficult to see happens. You implant the lens. You can see the margins of capsulotomy, and the principle of closest buttoning is used. So in circular movements, we stretch and implant the lens, which makes it ideally centered. And then the viscoelastic is removed, and this concludes the surgery. Intraoperative examinations shows that this groove of the lens contains two capsules, anterior and posterior. The lens is well centered, and around the capsular bag, this donut is so stretched that after some time, once fibrosis develops, it rarely retains transparency. Here we come to the part which is really important for the combined surgery. This is another example of good visualization. You can see the anterior and the posterior capsulae, both implanted anteriorly and posteriorly into the peripheral groove of the lens. After one of the talks by Professor Eckert, who uses only these lenses in combined surgery, I switched to this type of lenses as well. Implanting this type of lens takes a little longer, but if you were able to see how good peripheral retinal visualization is with this lens, please see there are no haptic elements and there is no square margin. Hence, changes in visualization of the periphery are virtually absent. It is way more pleasant to work in the periphery. Look how well we can see a flap tear even beyond the optic area, even if the tear is beyond the optic element. These lenses have their peculiarities. They are hydrophilic, so if we work on air or when we are doing the laser, posterior surface may become opacified, but visualization returns after at a later stage, and there is no problem moving on with the surgery. Everything is clearly visible. Here we are aspirating the subretinal fluid, and now we are performing the laser coagulation. This is what we can see through the lens covered with methyl cellulose. Unfortunately, there are some peculiarities. We need to dilate the pupil for vitrectomy. It is not very easy to constrict it on the operating table with pilocarpine or with other medications. Sometimes the constriction is just temporary because the mydriatic drugs, which we used preoperatively, act longer. So the gas in the sitting or supine position may compress the lens anteriorly, so luxation or infringement of a part of the iris in the same groove is a typical complication. Because it is important that we are able to take the patient to the operating room in case this happens. It is simple by pressing the optic part of the lens and administering some mydriatic the lens goes back to its proper position and returns to the normal position. Finally, this is a strange and unusual lens for standard cataract surgery, which is practiced in private centers. This is something difficult to imagine because there time matters, and it matters that we cover all expenses and the rest. When you are still learning, implantation may last up to 15 to 20 minutes. My best time was 12 to 15 minutes, but anyway, you need to count on 20 minutes. I think these additional 10 minutes bring a lot to the patient. They bring stable centering, and take a look at the advantages. Absence of PCO, PCO in 4 to 6% of cases, lower risk of posterior synechia. The lens is perfect for eyes with uveal cataract. It is just perfect. Posterior synechia cannot develop because behind the iris there is the lens. I'm concluding. I'm grateful to, and here is the book which was published recently in our clinic, added some information to this book. So I hope you will be using this lens in your practice. Thank you and have a good day.
And it's my greatest pleasure now to present Professor Novitsky's presentation, 4-point fixation of IOL in case of lens capsule absence. Thank you very much. And actually, I didn't mean to present that, but it's just there were lots of presentations on a lens fixation without capsular support. So I just decided to show another option. So it's 4-point fixation. So let us start to say that if it's just 2-point of fixation, so there is a tilting problem, lens tilting. And if we don't see that, it doesn't mean it's not there. Plus, there is a centration problem. And this tilting has been always bothering me. And I was thinking about other options, how else we can do the lens fixation. So it first started that there was a drop nuclear lens with 4 like parts, fixation parts. And I was thinking about that was just the beginning, introduction, and we need to continue. So while we are waiting for the presentation, Andrei, maybe we should discuss some questions or ask questions. Who has questions, please? Okay, I do have a question.
I have questions for you for anterior chamber IOLs. You propagated them so much. I have only one question. Can you answer why all the refractive anterior chamber lenses have been banned and stopped to be used if they are so easy and so innocent? So if refractive anterior chamber lenses are not innocent, so the IOL anterior chamber is not innocent either, because all the complications you have mentioned, for my opinion, they're much easier treatable than endothelial epithelial decompensation.
I mean, you're talking about phakic IOLs.
But the fixation is the same.
Well,
haptic
the
is the
fixation
same.
is pretty, yeah, but the clinical situation, I don't have much experience with phakic IOL. I was talking precisely about AC IOLs. And in relation to AC IOLs, I was talking about the patients and cataract surgeon skills when, the particular situation, when this lens could be really useful. And if you don't have a vitreoretinal surgeon next to you, or you don't have a vitreoretinal equipment, or you have a patient that cannot lie longer than half an hour, for example, or 15 minutes, elderly ladies, dedushkas, more than 80 or 90 years old, and they don't have money to pay extra for another surgery once you have to transfer them to a different specialist. So that would be the case when you can use those AC IOLs, and they definitely, it was not, I do have experience with using them. They were used just only in case, and I presented the, opinion of world leaders on this technique. And this technique is quite popular actually in the Western world.
Anterior
It's no
chamber
problem.
lenses are
I'm sure you know that AC IOL is just like that, because in some countries, some surgeons, they do have skills. They allow to work only as a cataract surgeon, like you mentioned before, and they're not allowed to work in the posterior segment. And in this case, also, like you said, you have to, once you started your surgery, you have to complete the case. It means you have to put the IOL and then transfer the patient to the vitreoretinal specialist. And by completing the case, that's what in the Western world, most of the anterior segment surgeons using this option in this kind
Thank
of
you very
complicated
much.
cases.
У меня вопрос к уважаемому Любомиру. Я не
I
знаю.
have a question to Lyubomir. I don't know whether Lyubomir is connected or not. Well, Andrei, then I have a suggestion. It's a very interesting method with holes formation. You have to patent it. It's an interesting method, needs to be patented.
Страшный инструмент, который я использовал для...
Yes, and now the surgeons saw this kind of terrible instrument that I used to form the hole. It's just the usual trocar, 25 gauge. I just cut the sharp edge, the sharp edge away, and that's it. 2.5 fixed. And if you use measurements and fix at 2.5 millimeters, you don't need to recalculate the optics, because you use the same refraction result if you put it intracapsularly into the capsule. But how do you measure? From which part of the lens do you start measurements? So when you start from the transparent cornea, it's one thing. When you start from the surgical limbus, here we can get the difference in 0.5 millimeter. Speaking about the tilting, if we use the Yamani technique correctly, we need to form the tunnel 2.53 millimeters inside, like the sclera, intrasclerally, and it's not a point fixation in this case, then intratunnel fixation. I will try to complete if I may. Okay. I have changed the technique into 2018. It looked like that. Marking the lens is in the eye. And then we go through the sclera and pass through the one loop of IOL and pass through the opposite side, and then we suture. And we have the lens. It's kind of, it looks quite nice. It's a little difficult, but well, it sits there nicely. So to do it inside the eye is not easy. So I thought maybe part of the manipulations could be done outside of the eye, and it looks like that. So first marking, and then we put the needles through the sclera, then through the cartilage, then through the two loops of IOL, cartridge, and through the corneal incision, fixation into the sclera, And here we put the lens into the cartridge, we implant it, we put the needle through the sclera, and then through the loops inside the eye, getting out and tightening. And then the IOL is centered. And that's how it looks like. I wanted to accelerate the video, but I didn't succeed in that. So just be patient. So this is going through sclera and tunnel. Cut. A vitreous eye, in this case. This is a post-traumatic case after traumatic retinal detachment, a iridia. There are some remnants of the iris, but practically nothing is there. So here the cornea is not very transparent. We also planned to do the cornea transplantation, and as far as I remember, vision was 0.1, and the patient actually does not want any transplantation. And this is going through the loops of IOL, and then we pass the needle through the cartridge. It looks like it's not too complicated, but, well, not easy at all. You will understand me. And now the needle is out of the cartridge. We did the IOL implantation, and now we're going through the loops inside the eye. And 30 more seconds, and we are done. Well, it's not 30 seconds, a little more. And again, and I have to mark where we need to get out with our needle. And now is the situation. We are going through the loops. We center the lens. It looks very central. No tilting. Thank you for your attention. There was no complication. That's true, no complication. And in all cases, there is nice central fixation. So maybe we have to think about that. Maybe it could be even improved more. Thank you for your attention. Thank you, Professor, very much. A very interesting technique. Yes, there is something to work on further. And now, if we have some questions for time for questions, so you're most welcome. If there are no questions, once again, thank you really very much, dear Professor, for invitation. Thank you to all the participants. That was a really interesting conference.
Tolerate this unbelievably good weather in Kiev, in Lviv, and thanks for everybody, and good luck and good evening. And we're looking forward for more good time in Lviv. Okay.
No microphone is engaged. Microphone is not used.
Не знаю, про кого вона говорить.
Доброго дня, шановні колеги. Ще раз
Good afternoon, dear colleagues. We would like to present a complex case. As you know, exudative retinal detachment is not a subject to surgical treatment, but in this case was special in some ways, which we will present. Coats retinitis is a truly rare retinal disorder which was described by George Coates in 1908. It is characterized by atypical development of retinal vessels with progressive intra and subretinal exudation, which in late stages may cause total exudative retinal detachment, secondary glaucoma, and even loss of the eye. Our case. Our patient, 16 years old, had Coats retinitis, stage 3B, with total retinal detachment, proliferative vitreoretinopathy, subretinal fibrosis, and visual acuity at ascension to light. At the age of 13, transscleral cryocoagulation of the retina was performed on the same eye with subretinal fluid removal. This is truly an effective technique in earlier stages of the condition. This prevents progression of the disease in 70% of cases. At that time, the visual acuity was 0.1, but due to proliferative retinopathy, this is what developed in the eye. As you can see, there is total exudation-related retinal detachment. There are marked subretinal conglomerations of exudation, fibrosis, subretinal, intraretinal. You can see peripapillary subretinal fibrosis. So we chose relaxic retinopathy, and I was hoping for easy removal of subretinal exudation. However, this is where I faced the problem. This huge conglomeration was intimately adherent to the choroid and to the retina, so I had to approach it from different sides. These minor exudations were easy to remove by triotomy. Could you please fast forward to avoid repeating itself?
Трошки раніше, будь ласка, включіть.
Please move forward, please move backwards.
Так, значить, те, що можливо було видалити, видалилось.
So we removed what was possible to remove. And on the other side, we tried mobilizing the retina and attempted removal of the subretinal conglomeration. This attempt was failed. However, then, in order to achieve anatomical adherence of the retina, we chose central retinotomy along the macula in order to achieve reattachment of the retina. After this manipulation, we were able to replace the retina to do a delicate laser coagulation along the retinotomy. Now we see this patient annually, and his visual acuity is stably at 0.06. As you can see, even in these severe cases, we must attempt achieving a result. Thank you for your attention.
Дуже дякую вам за таку гарну доповідь.
Thank you very much for your talk. Our next speaker is complex treatment of chronic central serous chorioretinopathy, Vitaly Adamchuk.
Доброго дня всім, шановні колеги.
Good afternoon, dear colleagues. I will try to quickly tell you about the patient who was followed for 5 years. So, however short I was trying to make it, the slides are quite numerous. In spring 2017, the patient presented with impaired vision, a spot in front of the right eye. His left eye has been weak for years. On the right eye, visual acuity is 0.1, on the left eye, 0.05. Preliminary diagnosis, chronic central serous chorioretinopathy, sclerosis of the right eye, orthophagy of the right eye. Fluorescein angiography identified accumulation of the dye, so we suspected hidden vascular membrane. We began by 2 sessions of micropulse laser coagulation on Iridex laser. This improved vision to 90% from 0.45 to 0.90. But after 6 weeks, the patient's vision deteriorated. After reassessment and talking to the patient, we identified the need for anti-VEGF. 3 months upon referral, the patient received his first aflibercept injection, which led to marked improvement of visual acuity and OCT. The patient's vision reached 0.95. 2 months later, the patient's vision deteriorated, and OCT identified marked elevation as well. After repeated laser coagulation, the patient's vision deteriorated as well, with stable OCT picture. Considering the lack of effect from laser treatment and marked positive response to VEGF, we confirmed the presence of a hidden vascular membrane. Anti-VEGF treatment was recommended, however, the patient refused. Because of severe visual deterioration, the patient agreed to continue treatment after 6 months. At that time, we performed 2 aflibercept injections, limited with 2 months interruption. The patient's vision returned to 0.75. After 6 weeks, the patient's condition deteriorated again. As an alternative, we proposed subtenon injection of diprospan, which produced a short-term response. The patient's condition required further anti-VEGF, but because of the patient's inability to financially support this treatment, 2 treatments of bevacizumab were performed. Reactivation of the process happened twice in 2-month intervals. After injection of bevacizumab, OCT shows clinically significant cystic inflammation, edema. Repeated injections led to improvement of the vision, although not as much as initially. Considering permanent recurrences of the condition on the better eye, the second eye being affected with subretinal fibrosis, it was recommended to perform injections every 8 weeks and to go back to aflibercept. The patient's lens was removed and toric IOL was implanted. After that, the patient's vision improved to 95%. This is the graph showing the patient's visual acuity over the span of follow-up period. The patient did not adhere to this recommendation, and the patient was lost to follow up. And after 6 weeks, he presented with major cystic edema with marked visual deterioration. And the EGF produced good response, but only with partial recovery of vision. Over the span of 6 months, the patient received 3 injections of aflibercept, which improved his vision to 0.75. Again, another recurrence and 4 more bevacizumab treatments because the patient was unable to cover financially aflibercept, although recommended to. The patient, this led to marked improvement of the neurosensory epithelium. On OCT, however, his vision improved to 0.60. This is what was happening with the patient's visual acuity between 2020 and 2021. So we follow our patients based on evidence-based protocols. However, severe pathologies combined with financial and social factors cause us to deviate from standards and to look for individual ways to achieve good outcome. Patient incompliance almost always affects further course of the disease, so increasing patient awareness is in no way less important than the treatment itself. Thank you very much for your talk and for diligent treatment for the patient over the long span of time. Our next speaker is Dmytro Horachev, a nail under the retina.
Все гаразд? Дякувати Богу. Може, ми тоді розпочнемо іншу доповідь, щоб не втрачати час?
Let us proceed to the next talk, and in the meantime, you will prepare the equipment.
Сергій ну, може, 3 хвилини втратити.
Good afternoon, everyone. This is our complex case, nail under the retina. We saw the patient several weeks after the injury. He does not recollect the injury itself. At a local clinic, ultrasonographic signs of detachment were observed, and retinal detachment was referred to our clinic. Indeed, I saw a foreign body under the retina, so I proceeded to the surgery. I'm administering triamcinolone, elevating the posterior hyaloid. As you can see, the retina is detached. I was unable to identify the entry hole in the retina. PCFL tamponade in order to compress the subretinal fluid a little bit. And then I asked myself, do I leave the nail forever and just drain the subretinal fluid? However, I thought it wouldn't be a good idea, and I chose to remove the nail. Coagulation in the area where I was planning to remove the nail, retinotomy. And now we need to carefully, in one movement, simultaneously to remove the foreign body from below the retina and to take it out through sclerotomy. So it took me 5 minutes to sit and think, how do I do that? I was trying to calculate all the eye movements, considering the eyeball dimensions, approximate dimensions of the nail, and this is what it looked like. In order to avoid tearing anything, and this was the motion, I was also trying to avoid touching the chorioid in order to avoid hemorrhage. Take a look. Now I'm showing the piece, the metal, in order to remove it outside in one movement. I extended the incision a little bit, and we are delivering the nail. Basically, that would be it. I'm suturing the sclerotomy. Subtotal vitrectomy followed. I'm draining the fluid through the same tear that was through the retinotomy, which I had performed. Coagulation around the retinotomy. And silicone endotamponade. Prior to surgery, the vision was at 100th, and 2 months after silicone removal, ophthalmoscopy is at 0.3. The visual acuity is 0.3. Thank you for listening. Thank you for the interesting recording. It's the second time we see it, and it's the second time we like it. Our next talk, Cherkasy, Poltava, combination of central chorioretinopathy, central vein thrombosis, and chorioretinal neovascularization, all in one eye. Welcome. Good afternoon, dear colleagues. I'm happy to welcome you to this live symposium. Let's proceed to our case. We saw a patient, 55 years old. In 2014, we performed OCT, identified detachment of neuroepithelium. Hence, conservative treatment was administered, and this gave good outcome with adherence of the neuroepithelium. The patient had no symptoms, and he came again in 2018 with similar complaints, symptoms, including visual acuity deterioration.
Проблема з указкою.
There was some problem with the pointer.
Повторне ОКТ виявило більше.
The OCT showed higher height of epithelium. We continued with conservative treatment, didn't yield any good results, and 1 month after, central retinal vein occlusion develops, and there is increased square of neuroepithelial damage. And then next we did the angio-CT in this patient, and it showed chorioretinal neovascular membrane. And because of that, the patient had 4 intravitreal injections of aflibercept. It didn't yield any positive result, and neuroepithelium didn't attach, and the visual acuity didn't increase. And that is why we did the first FA parafoveal leaking point was found. The height of the edema is quite significant. Retinal edema, and we're thinking what to do, and we decided to do the focal laser coagulation of the leaking point, and it gave a good result. And 1 month later, the retinal looked like that, and the patient had 100% visual acuity, no complaints. And next time he came 4 months later, we do the CT, neuroepithelium detachment, we do fluorescent angiography, we found the leaking point. Again, it was parafoveal, and we decided to do the repeated laser coagulation. It was successful, and 2 weeks later, patient looks like that on OCT, and neuroepithelium attached, and the visual acuity increased up to 100%, and no complaints. In 2020, it was quite difficult because of the pandemic, and the patient didn't present for visits. And in February 2021, and we can see this picture in OCT, and retinal profile is good, normal thickness, retinal thickness, and visual acuity is normal. Thank you for your attention. Thank you for this very interesting presentation, and the floor is given to Mr. Konstantin. He represents the group of authors from Vinnytsia. Surgical treatment. Again, you're most welcome, dear ladies and gentlemen, welcoming you. So it's surgical treatment of retinal arterial microaneurysm. Macroaneurysm complicated by some sub-ILM hemorrhage. Some briefly about the disease. Arterial macroaneurysm develop in patients with hypertension retinopathy. In the arteriolar area, in 40% of cases, it's in the area of macula. In 40% of cases, lower temporal area, and in the rest of the cases, nasal. There are 3 stages of the disease, late and exudative and hemorrhagic. Usually the patient comes to a doctor when his vision worsens significantly. And this is a clinical case, 61, male, complaint, sudden vision loss in the left eye, so vision 20/20 OD, OS 20/200, a concomitant disease, hypertension, hypertensive retinopathy of both eyes, retinal arterial macroaneurysm, and with sub-ILM hemorrhage on the left eye. So this is a clinical picture. We can see a huge hemorrhage under the ILM, internal limiting membrane. In patients with arterial macroaneurysm, usually it happens multi-layer hemorrhage. It's under the ILM and in subretinal space. In this particular case, you can see a huge bleeding under the ILM, and it deforms the fovea, and there is a very thin subretinal bleeding. The patient was offered vitrectomy 25 gauge with peeling of ILM, and now we will show the video. Waiting for the video. Now you can see the peeling of internal limiting membrane.
Видалення згустку крові з поверхні сітківки.
The blood clot was taken on the surface of the retina, and we can see now the macroaneurysm. Then a liquid air exchanged, and so anti-VEGF was injected 3 times actually, and we stopped at that. 6 months after that, we can see a normal fovea, and the exudates subsided, and vision 0.4 centrally. Thank you for your attention. Of course, wonderful results. Congratulations. And we still have a couple of minutes for questions if we have them. The audience. Andrei? Microphone is not engaged. No microphone is used. No microphone is used. Sorry, we need the microphone.
Шановні колеги, я думаю, що я перепрошую за те, що я перебиваю таку цікаву.
Dear colleagues, I'm sorry for interrupting such a lively discussions, but I'm afraid we have already used our time for questions. It's a very interesting topic. I'm sure any one of us can ask a lot of interesting questions, and that will enrich us, but we don't have any more time. Next presentation. So massive submacular hemorrhage shift. And the next presentation, you're most welcome. Hello, dear colleagues. It's a short case of the pneumatic displacement of massive subretinal hemorrhage that we would like to tell you about. Patient came with complaints in left eye vision deterioration 3 days ago. She started to have her complaints after the hypertensive crisis. She was not treated and she didn't seek any medical care, actually. So we saw the following in the macular area in the left eye. There was quite a big subretinal bleeding. Vision was 0.05. No special specific changes in the other eye. So what we have decided right away to use to do anti-VEGF injection, and then vitrectomy with removal of ILM and gas tamponade after the mobilization of the retina with saline. And of course, consultation of the cardiologist. So first we did the closed vitrectomy and posterior hyaloid membrane removal. Triamcinolone is used for staining and better visualization of hyaloid, posterior hyaloid. Then the dye was used to better visualize the membrane, and we tried to remove it, and it looked like we succeeded. Then we did the point retinotomy. And through the retinotomy, the saline was injected. Laser for coagulation. That place of tear. And the saline was introduced under the retina. After that, the gas tamponade was done. So for 2 or 3 weeks, there was a gas tamponade, and the C3F8 gas was used in this situation. This is before and 3 months post-operatively. So 3 months after surgery, we can see the OCT picture like that. So bleeding is practically not there. And during those 2 or 3 months, we were injecting anti-VEGF drugs. And then the next visit was planned 1 or 2 months later. She was supposed to come, but she disappeared, and we didn't see her for 3 years. 3 years later, she came because, again, after problems with hypertension, she noticed worsening of vision, and just remembering the last case, she decided to come here for consultation. And over the 3 years, the visual acuity was very good, even improved, stable condition. The only thing that on the surface of the retina, we can see the formation of the epiretinal membrane. So now we are thinking about second surgery to remove it. So using this technique proved to be an effective method treating the subretinal hemorrhage, and to our opinion, a good guarantee of stabilization of this visual acuity is timely treatment and timely intervention of eye specialists. Thank you for your attention. Thank you for this interesting presentation. Absolutely good result. If we didn't have lack of time, of course, we could have discussed that and what else could be done short time after the bleeding. We could use for plasminogen methods and use more delicate methods of intervention, but we are not succeeding in terms of time-wise. So we have to think whether we have problems with submacular membranes, or we don't have such problems, and how do we manage patients? I'm sorry, I'm not giving you any opportunity to ask questions because you are living in the same city. You have this opportunity to do it outside of the conference, because we still have a very interesting Stanislav Takson, Kravets Teslenko from Kiev, Ukraine, group embolysis in central retinal vein occlusion. You're most welcome. Hello, dear colleagues. In principle, the case that I wanted to show you, I've already shown you a couple of times. So we've demonstrated to you a couple of times, but maybe to comment on it a little more, we are showing it again. I am working, first of all, embolysis, so central retinal artery occlusion or branches occlusion. Something that we can do different ways. It's always a serious problem that will not allow usually to get the vision back to the level it was before, with some exceptions, rare exceptions, but they happen nevertheless. Here, before we switched over, like we will see the video later, but first fluorescent angiography, there is an occlusion of the branch of the central artery. You can see an arterial face. The top left corner is showing what we had before intervention. Quite high visual acuity in a patient, 40–50% the patient is reading, but he is complaining of a kind of a blinder. We can see an embolus on the optic nerve disc, and I will try with the help of a laser to get rid of that. And in this case, I have retinotomy, while I will switch on my emotion that and how I felt back at that time. So I was very emotional at that time, and my colleagues were looking at me like that. So the manipulation itself, the help of a disruptor. So the embolus is not fragmented, but the vessel is breaking, and we see the arterial bleeding. So that's how I felt at that moment. You can imagine. And later on, pressing against this bleeding with the lens. So I'm pressing with the lens. Well, it's better, but still the blood is getting out, and the embolus is still there. Now I'm going to make a second attempt. So I've already overcame my emotion, so I decided to move on. I will have another attempt to get the embolus out of the vessel. It's difficult to focus, and this patient is hypertensive. Again, another shot. This bleeding is even more massive, and the blood covered the embolus. Possible to do anything, but bleeding stopped, and we are going to see the fluorescent angiography. That was done after this intervention. When the patient got out of the procedure room, he said that he feels much better, that this blinder almost disappeared, and he was able to read 0.7 vision, and next day 95% reading was there in the patient. So you can see before and after, so 10–15 minutes after, while we were getting ready to do the next fluorescent angiography. You can see pictures approximately in the same phase. The left top one is before, so the upper line, but to the right you can see what happened after the procedure. You can see that it led to vision improvement, and also you can see this film and this and other videos on my webpage and Facebook. Thank you very much. Thank you. we would like to thank all the presenters, all the speakers. Thank you everyone who came to listen to all this. I'm very happy that we had this opportunity to get together to discuss, and they're waiting for us in a minute in the general in the main hall. Please go there, proceed there. Thank you.